am Biswanath, and today we are going to revise the neurophysiology, that is the whole neurophysiology. So I will cover just the important parts of your neurophysiology topic, like all the tracts and all. So it's gonna be a good revision for you also. Okay, so let's start with the motor system now. Okay, we'll do the motor system first. So from the motor cortex, your motor tracts come, descending tracts come. Okay, so motor tracts and this from spinal cord, this come to the muscles, and muscles contract, causing movements. Okay, so motor tracts, we can have motor tracts. Just let me make it thin bit. Yeah, so we can have motor tracts. So in motor tracts we can have lateral descending tracts, okay, and we can have your medial descending tracts, okay. In a lateral descending tracts we can have your lateral corticospinal tract, which are for fine voluntary movements, okay. And we can have your rubrospinal tract. This is for a flexion of upper limb, okay, flexion of upper limb. So rubrospinal tract generally rises from a red nucleus, the red nucleus of your midbrain to the spinal cord, okay. This all tracts go from your brain to your spinal cord, okay, brain to your spinal cord, your motor cortex of the brain to your spinal cord. And medial descending tracts, there are 4 medial descending tracts here, okay, 4 medial descending tracts here. Here also we have your corticospinal tract, but this is a lateral corticospinal tract. Here we have your medial corticospinal tract, okay. Then you have tectospinal tract. Then you can have vestibulospinal tract, okay. And then we have your reticulospinal tract. Understood? These are your medial descending tracts, okay. In medial descending tracts, let's say we have the medial corticospinal tract, okay. So medial corticospinal tract is generally like medial, okay. So we can it controls the trunk muscles or your axial muscles which are present near the midline, okay. So it is help in postural control, okay. This all tracts, medial descending tracts, is all help in postural control, okay. This controls your axial muscles. Then we have the tectospinal tract. Tectospinal is a tectum. It is related with the vision, okay. The colliculi. So it regulates the eye movements, okay. This regulates the eye movements. Then your vestibulospinal tract, the vestibulum, okay. So vestibular apparatus related with the balance. So it maintains the balance and equilibrium. Then we have your reticulospinal tract. This causes extension of all 4 limbs. So here we have the extension of all 4 limbs caused by reticulospinal tract. Then coming to your so this is your introduction, okay, how the voluntary movements are controlled. So here we have the control of voluntary movement, how the voluntary movements are generally controlled, okay. So we can first have the idea of movement. That I want to do this movement. We have to plan the idea of the movement, okay. Then we plan how to do the movement, okay. This is what to do, okay. This is what to do, and this is what this is how to do, okay. Then we can have postural setting, okay. We can set up our posture and then we can execute, okay. Then we'll execute postural setting. This is ready. Are we ready for the movement? And execute is doing the movement actually, okay. So idea of the movement comes from your cortical association areas, okay. And your planning of the movement, how you plan, comes from 4 areas, okay. This comes from a supplementary motor area, this comes from a premotor area, this comes from a basal ganglia and your cerebellum, okay. Supplementary motor, premotor, basal ganglia and the cerebellum. Posture is set by your premotor area, okay. Premotor is also involved in your planning and also in your postural setting. And execution is done by your motor area, okay. This stimulates your corticospinal tract. This goes to your spinal cord, okay. spinal cord, and spinal cord causes the muscle to contract, okay, and movement occurs. Understood? So if we have the problems in few areas, okay, like we have the problem in your premotor area and your supplementary motor area, these two areas are problematic here, okay, these are not working, so we can have a disorder called as apraxia, okay, apraxia. Understood? And you have the disorder of primary motor area, then you can have hemiplegia. So 1 2 Brodmann areas, 1 2 3 4 5 6 7, we have like this. So 1 2 3 5 and 7, these are your sensory areas, sensory. And what are the motor areas? This is your 4 6, these two are your motor areas, okay. So Brodmann areas 4 and 6 are your motor areas. Understood? So what is apraxia? Apraxia means inability to plan. You cannot plan a movement, okay. This is also called as learned disability, learned disability, learned disability, okay. Understood? And we have a thing called as the bimanual coordination, a thing called bimanual coordination, bimanual coordination. This is maintained by your supplementary motor area. Bimanual coordination means you both sides of body are working coordinatedly, like you throw a ball and someone catches it with two hands, okay, someone is catching the ball with its two hands. So this is bimanual coordination, okay. We can have a concept called as the mirror neuron concept, the mirror neurons, so this is generally for mimicry, okay, like mimicking of neuron, okay. This is highly active in your children, so they tend to learn what are the adults are saying, okay. This mirror neurons are present in your premotor cortex, okay. Your premotor area, the premotor cortex contains mirror neurons. So we can trigger this mirror neurons, so as to treat the learned disability or your apraxia. So treatment of apraxia involves the triggering of mirror neuron, which is a newer concept here, okay. So let's discuss about the corticospinal tract, okay. Let's discuss about the corticospinal tract. So corticospinal tract have two types of fibers here. We can have decussated fibers, we can have undecussated. That is the crossed fibers and the uncrossed fibers. 80% are decussated and 20% fibers are undecussated. From this decussated, 70% fibers terminate on inhibitory interneuron, okay, and 30%, around 30% terminate on your anterior horn cells. Understood? Okay, so this is about your corticospinal tract, about the fibers, okay. Let's discuss the corticospinal tract now, okay. This is a descending tract, so we will come above from the brain, okay. Let's draw the things that are required. Let's draw this is your motor cortex or a Brodmann's area 4, okay. So this comes, the fibers come from the motor cortex. These are radiations. This is the posterior limb of internal capsule, this comes to here. Then the fibers go like this cross the midbrain at the level of cerebral peduncles, okay. Then go down, they cross the pons. Which part of pons? The basilar part of pons, which part of pons? The basilar part of pons. Then go down again, okay. Let's say this is the midline of the body, okay. This decussate at the level of medulla oblongata, so decussated fibers are how much? About 80%. Majority of fibers are decussated at the level of medulla oblongata. So here I have 80% fibers and here you have 20% fibers, okay. So 20% fibers which forming the anterior corticospinal tract, or your which corticospinal tract? Medial corticospinal tract, which we saw just now in descending tracts. The medial corticospinal tract, which regulate the axial muscles, okay. And this 80% fibers which are coming here, okay, here we have the your spinal cord, okay, from the spinal cord here. So 80% fibers, from these 80% fibers, about 70% terminate or inhibitory interneuron. Here is an interneuron here. Okay, here is an interneuron. This is inhibitory. So terminate on inhibitory interneuron, and your 30% terminate on your, this is your anterior side, this is the posterior side. So this terminate at the anterior horn cells, AHCs. Okay, okay, anterior horn cells. And this is your medial corticospinal tract, again decussates and terminates on your anterior horn cells. So let me trace the tracts. So let's say this one, motor cortex 4, posterior limb of internal capsule, midbrain at the level of cerebral peduncles, pons at the basilar part of pons. Let me trace the medial corticospinal tract. So it goes like 20% fibers go here, goes here at the level of spinal cord, they decussate and end at anterior horn cells. This is your medial corticospinal tract. Your lateral corticospinal tract, this is motor cortex. This come from your posterior limb, midbrain cerebral peduncles, pons basilar part, goes down here. 80% fibers cross from here, and from this 70% are terminating on inhibitory interneuron, on 30% on anterior horn cells again. Okay, this completes your pyramidal tract. So let's say from here, okay, from here the anterior horn cells, okay, this is a spinal cord, I assume. Okay, so this must be terminating here like this. So from this anterior horn cells, from the cells known as anterior horn cells, okay, anterior horn cells, arise the fibers called as A alpha fibers, and some fibers which are A beta fibers, and your lower motor neuron also. Okay, understood? So A alpha and A beta. A alpha fibers are this A alpha and A beta, this both, okay, this both help in muscle contraction. Just remove this lower motor neuron fibers, you may be confused. So since A beta and A alpha, these are the lower motor neurons. Below the level of spinal cord are the lower motor neurons, and above the level of spinal cord are your upper motor neurons. Okay, so these all are there. Understood? Okay, these are from which fibers? The undecussated fibers, the 80% fibers which were coming there. From the decussated fibers arises a lower motor neuron, LMN, which supplies the axial muscles or your midline muscles, axial or your midline muscles. Understood? Done. So from this applied aspects are there, like most common cause of hemiplegia is the superior half of your internal capsule. Okay, so if there is damage to the lenticulostriate branch, okay, lenticulostriate branch of medial cerebral artery, this is the major cause of hemiplegia. This is the most common cause. Okay, so we have damage to midbrain. If midbrain is damaged, okay, if midbrain is damaged, we can have a syndrome called as Weber's syndrome. Weber's syndrome. What is Weber's syndrome? This is the damage to midbrain. What is caused here? Contralateral hemiplegia. Contralateral hemiplegia means opposite side paralysis, and ipsilateral means same side third nerve palsy. Understood? So contralateral hemiplegia and ipsilateral third nerve palsy causes Weber's syndrome. Then we can have damage to pons. If pons is damaged, you can have three syndromes here. Three syndromes, what are they? One is the Raymond syndrome. One is your Fobili syndrome. Raymond, Fobili, and another is a Millard-Gubler syndrome. Understood? Raymond, Fobili, and your Millard-Gubler syndrome. So what are these three syndromes? So in Raymond syndrome, you can just write contralateral hemiplegia here also, and here also. Contralateral hemiplegia occurs here also. In Raymond syndrome, it is sixth nerve palsy. In your Fabili and Miller Gubler, okay, you can have sixth and seventh both, sixth plus seventh nerve palsy. Understood? Then we can have damage to midbrain is done, damage to pons is done, and we can have damage to medullary damage. You can damage to medulla. We can have a syndrome called as Dejerine syndrome. Okay, Dejerine syndrome. In Dejerine syndrome, you can have contralateral hemiplegia as well as ipsilateral 12th nerve palsy. Understood? Contralateral hemiplegia and ipsilateral 12th nerve palsy. So you can observe that in all the damage, midbrain, pons and medulla, this hemiplegia is common, that is contralateral side. Okay. If midbrain is damaged, your third nerve palsy. If pons is damaged, your sixth and seventh nerve basically are damaged. The medullary damage, the 12th nerve is damaged. How do you remember? 3 is above, then comes 6th and 7th, then comes 12. Okay. So as we move down, midbrain, pons, medulla, 3, 6, 7 and 12. Okay, understood? So then you can have damage to your upper motor neuron, lower motor neuron, UMN disease, and then you can have LMN disease. So in UMN disease, okay, what are the examples? Examples of UMN disease is corticospinal tract lesion. Okay, corticospinal tract lesions. And LMN disease example is AMS. What is AMS? Amyotrophic lateral sclerosis, or this is called as low grade disease. Okay, in this what happens that your all the paralysis is occurred. Okay, lower motor disease, like you must have observed the Stephen Hawking. Okay, a great scientist who wrote that black holes and theory and all. Okay, so he suffered from AMS. Okay, he was a AMS patient. And another example is a poliomyelitis. Okay, understood? In this UMN upper means up. So what must be occur? You will have hypertonia, increased muscle tone. You can have hyperreflexia, increased sensitivity of reflexes, increased reflexes. Okay, toes up. What do you mean by toes up? That means Babinski sign positive. Okay, what is Babinski sign? I will tell in a minute. Okay, then we have lower motor. Lower means down means we can have hypotonia, hyporeflexia, and you can have Babinski, like toes niche. Okay, so you can have Babinski sign negative. Understood? What is Babinski sign? That if you run a sharp instrument along the lateral border, from the lateral side to the medial side, like this. Okay, just imagine a feet here, and this is the great toe hallux. Okay, from the lateral side to the medial side, if you run some instrument like this, okay, then the big toe extends, and your other toes fan out. Okay, like they separate from each other. This is called Babinski sign. So this is called Babinski sign. This is abnormal. Okay, what is the normal thing? If you toes go down, this is the normal thing. Okay, toes go downwards. Okay, this is Babinski sign negative. Toes go downwards, this is normal. Toes goes downwards, so this is negative Babinski sign. In LMN lesion also negative Babinski sign. In UMN lesions, toes go up, okay, and fan out. So you can have positive Babinski sign. And in infants also you can have positive Babinski. Understood? This is done. Then we have a topic called as alpha gamma coactivation. Okay, so if you just know the structure of a muscle spindle, it would have been easy. Let's discuss it just in a minute. Okay, let's say here is a muscle spindle here. Okay, this is a this is a muscle fiber. Okay, this whole thing is a muscle fiber here. Muscle fiber is there. Then we have below it your extrafusal muscle fibers. This is your extrafusal muscle fibers, and then inside we have intrafusal muscle fibers. This is intrafusal muscle fibers, and here we have a muscle spindle. This is your muscle spindle. Understood? So what are the things that are innervating, what are the neurons that are innervating this fibers? Okay, so here we have the spinal cord, and A alpha and A gamma are arising. Okay, A alpha is arising. Where it is going? It is stimulating the extrafusal fibers. A alpha stimulates the extrafusal fibers. Understood? Then we have the second one. What is that? That is your A gamma. A gamma stimulates your intrafusal fibers. A gamma stimulates your intrafusal fibers. Understood? A alpha your extrafusal, A gamma your intrafusal. So we will just learn in a minute how does. First, let's talk about A alpha. So A alpha stimulation is seen in a neuromuscular junction, the normal neuromuscular junction, which I hope you must be knowing. So let me just discuss some neuromuscular junction in a minute. Okay, so first what happens? First is your Na plus VGC is open. Okay, so action potential starts means here calcium channels open. Calcium channels causes movement of vesicles which contain the ACH. Okay, ACH binds to the nicotinic receptors. Okay, due to nicotinic receptors binding, the sodium voltage gated channels on postsynaptic membrane on your your muscle opens. Okay, action potential is generated. Okay, after generation of action potential, where? In your muscle fiber. What has happened? This calcium is dragged out of sarcoplasmic reticulum, and due to sarcoplasmic reticulum, calcium unmasks the tropomyosin that is covering the active sites on the myosin. Okay, so actin myosin movement is there, and your muscle is contraction. Understood? So this is your neuromuscular junction. What are the applied aspects of neuromuscular junction? Some applied aspects of neuromuscular junction are there. Like what are the things that are happening? So opening of sodium voltage gated channels, this is blocked by a toxin called as a tetrodotoxin, which is present in a pufferfish. Okay, pufferfish tetrodotoxin, which blocks the sodium voltage gated channels. So all the things are, muscle contraction is blocked. All these things are blocked. Then we are starting the action potential, the opening of calcium entry. Okay, so in Lambert-Eaton syndrome, we have a syndrome called as Lambert-Eaton syndrome. Okay, this voltage gated calcium channels are blocked. This calcium VGCs are blocked. In which syndrome? This is called Lambert-Eaton syndrome. In Lambert-Eaton syndrome, this calcium voltage gated channels are blocked. And then we have your movement of vesicles containing ACH. Okay, so this movement of vesicles required the use of some proteins called as snare proteins. Okay, snare proteins. What are the snare proteins? We have synaptotegmin. Okay, synaptotegmin, synaptobrevin, then we have syntaxin, and then we have SNAP25. Okay, this is some divided into T snares and B snares. This fuse and cause the binding of the receptor of ACH, the vesicle containing ACH, to the presynaptic membrane ready for its discharge, used for docking of the vesicle. Okay, so ACH binds to nicotinic receptors. So binding of ACH to nicotinic receptors is inhibited in the disease. Just guess the disease. Yes, it is myasthenia gravis. Why it is blocked? Because auto antibodies are present against the ACH nicotinic receptors, so it prevents the binding of acetylcholine to it. Okay, understood. Then we have some other things like calcium is released from a sarcoplasmic reticulum. Okay, this calcium release from sarcoplasmic reticulum, this is via some receptors which is called ryanodine receptors and your DHP channels. Okay, ryanodine receptors and DHP channels. Understood? So ryanodine receptors are inhibited in the by a drug called as dantoline sodium. Okay, dantoline sodium inhibits your ryanodine receptor. Understood? So because if there is overactivity, then calcium increases, and calcium causes more contraction. So due to more contraction, heat production increases. Due to this heat production, we can have a disorder called as malignant hyperthermia. Okay, this to treat this malignant hyperthermia, we use dantoline sodium. So snare proteins, we have the 4 snare proteins here. So snare proteins are blocked. This syntagmin is not blocked by anyone, but synaptobrevin is blocked by your botulinum B. This is blocked by your botulinum C. This is blocked by your botulinum A and E. Understood? Okay, this are required for the release of ACH. Okay, so Clostridium tetani, then we have a thing called Clostridium tetani, okay, which blocks the GABA and glycine inhibitory neurotransmitter, which increase the ACH. So exaggerated contraction is there and spastic paralysis occur due to Clostridium tetani. Okay, then we have a ACHE, enzyme called as ACHE. So I'm discussing all the important points that are required in the neuromuscular junction. Okay, so let's continue discussing it. So we have ACHE. Understood? ACHE. What is ACHE? Acetylcholine esterase enzyme which degrades ACH. Okay, degrades ACH. This pesticides and insecticides in OP poisoning, organophosphorus poisoning, this inhibits your ACHE enzyme. Okay, pesticides and insecticides have organophosphorus, so organophosphorus poisoning may inhibit your ACHE. Understood? If ACHE is absent, then ACH increases. ACH if increases, it will start a parasympathetic pathway. Okay, parasym activity. Okay, frothing and bubble secretions are increased. Okay, like frothing and bubbles are there. So ACHE blockers are used to treat your myasthenia gravis. What are the drugs which block the ACHE? So we have physostigmine and your neostigmine. Okay, these are your ACHE blockers that are treatment of myasthenia gravis. Understood? So sarcoplasmic action potential travels. What is a triad? If you don't know, let me tell you what is a triad. Then in the sarcoplasmic reticulum of your muscle cell, these are some invaginations called as your T tubule. Okay, and here we have the SR, sarcoplasmic reticulum, and here is a sarcoplasmic reticulum here. So this whole part is called as a triad. Okay, this is called a triad. Understood? This is a triad. In cardiac muscles, you must have heard that a triad is absent, a dyad is present. Understood? So here what happens, that sodium influx is there, the action potential is generated, action potential travels, it moves by the T tubule. Okay, action potential reaches here. Here we have some tiny calcium channels here. Okay, here is a calcium channel. It stimulates the calcium channel, due to its calcium goes inside. Calcium, this is a DHFR. Okay, DHFR. Okay, and here you have some ryanodine receptors. This is a ryanodine. DHFR and ryanodine touch, and which causes the release of calcium, more and more calcium from your sarcoplasmic reticulum. Understood? So you know actin and myosin, what are the things that are there in your actin and myosin. Okay, generally in your resting state where there is no contraction, in a relaxed state, okay, the tropomyosin is there, tropomyosin, which covers the active site on myosin, active site on myosin covers it. Okay, so on release of calcium, okay, calcium which masks the active, which just opens up the tropomyosin slides, causes the conformational changes, and myosin head can now bind, okay, form the cross bridge formation is there, which pull and cause the muscle contraction. This is called as sliding filament theory, given by Huxley and Huxley. Okay, and the relaxation of muscle requires ATP, and this relaxation also requires ATP. So after death, okay, there is a dearth of ATP, so due to dearth of ATP, the body remains in contracted state. Okay, body remains in the contracted state, which is called as a myasthenia, sorry, not myasthenia, which is called as a rigor mortis. Okay, rigor mortis. This is also used in your forensic studies, your to know the time until death. Okay, time until death. Okay, time until death sets in within 3 to 4 hours after death. Okay, 3 to 4 hours after death it sets in, and due to decreased ATP, and completes in about 12 hours. Okay, completes it about in 12 hours, complete about 12 hours. Okay, and disappears after 40 to 60 hours after death. That means your 4-5 days it will just disappear. Okay, in 2 to 3 days or 4 to 5 days it will just disappear due to muscular degeneration. Muscles are degenerated due to loss of ATP. Okay, to know the time until death it is used, and also to know nature of death. Okay, it is also used to know the nature of death, which is of medico legal significance. Okay, this is a normal A alpha fibers, but we want to discuss the A gamma motor neuron fibers. Okay, the role of A gamma in contraction, Okay, so to know the role of A gamma, let's draw the same diagram as we've done of A alpha. So A alpha and A gamma are co-stimulated. Okay, they're stimulated just like this. So here is the muscle fiber. Let's say this is the muscle fiber. Then we have extrafusal and intrafusal fibers. Here with the extrafusal fibers. Okay, then we will draw the intrafusal fibers. This is the intrafusal fibers. Okay, and covering the intrafusal fibers is your muscle spindle. Muscle spindle contains 2 intrafusal fibers. Okay, so intrafusal muscle fibers, will see how it is just happening. So we'll zoom in into that muscle spindle here. So here is the muscle spindle. Here we have to zoom in. It will cause confusion if I draw this like that. So here is the muscle spindle. Okay, let's zoom in the muscle spindle. So here is the boundary of a muscle spindle. I'm drawing it in blue. Here is the muscle spindle. Don't confuse it with muscle fiber. This is a muscle spindle. So muscle spindle contains some fibers. Okay, what are the 2 types of fibers? One is the bag fibers, one is the chain fibers. 2 types of fibers. One is the bag fibers, one is the chain fibers. These are 2 types of fibers present. So bag fibers are just like this, shaped like this. Okay, this is also a bag fiber. 2 bag fibers. Let's draw 2 bag fibers. And chain fibers, let's draw about 5 chain fibers. These are present in that ratio. Okay, 2:5 ratio, 2:5 ratio in present. Okay, these are the fibers. Okay, in the muscle spindle, these upper 2 are your bag, and this lower 2 are chain like shape. This is the chain fibers. Understood? So let's start. What are the events that are happening? Okay, so A alpha, from here arises A alpha. Let's draw it with black. A alpha stimulates your extrafusal fibers. Okay, sorry, not this one. Is extrafusal fibers. Okay, they stimulate your extrafusal fiber, and your this is a alpha, and your A gamma stimulates your intrafusal fibers. This is your A gamma, which stimulates the intrafusal fibers. Understood? Intrafusal and extrafusal fibers. Understood? And from the muscle spindles, okay, after stimulation of intrafusal fibers, a fiber called as 1A, okay, fiber called 1A, this comes 1A comes and stimulate your 1A comes and stimulate your bag fiber. They stimulate your bag fiber. Okay, so bag fibers, we have two types of bag fibers here. Okay, and the bag fibers are also of two type. One is a dynamic bag fiber. Okay, another is static bag fiber. Okay, dynamic and static. So it stimulates the dynamic bag fiber. Understood? Stimulates the dynamic bag fiber. So if you just look at a bag fiber, this is shaped like this, but the contractile proteins are present in the periphery. So it stretches. Okay, bag fiber stretch after stimulation by 1A fibers. It stretches. Due to stretching, it stimulates the 1A, which stimulates the A alpha, which contracts the extrafusal fibers. And due to the contraction extrafusal fibers, the muscle is contracted. Okay, understood what happened? What happened is that, look at this. There's a bag fiber. Okay, due to the stimulation of your A gamma fibers, A gamma stimulate your bag fiber. Okay, this bag fiber contract. Bag fiber contraction stimulated your 1A fibers. This 1A fibers, okay, this stimulate in turn your A alpha fiber, and this A alpha fiber cause contraction of extrafusal muscle fibers, and due to extrafusal muscle fibers, the whole muscle contract. Understood? So this is the whole mechanism of control. Okay, so what are the factors that are affecting the A gamma motor neuron discharge? Okay, what are the control of A gamma motor neuron discharge? So we have a tract called as the reticulospinal tract. Understood? Reticulospinal tract. So reticulospinal tract, we have two reticulospinal tracts, one from pons and one from medulla. So the one from pons that stimulates the A alpha, and one from medulla inhibits the A alpha. Just remember like this. Okay, other factors is called A motor neuron discharge, anxiety. Okay, anxiety, and a term called as Gendra 6 maneuver. Gendra 6 maneuver. Gendra 6 maneuver, like clenching your fist and your grinding your teeth so that your reflexes are faster. Okay, you have to clench your fist so as to get nice reflexes. In the patients in which the reflexes can't be seen, the physician may advise for your Gendra 6 maneuver to test the reflexes. Okay, this is that. Another thing very important is the UMN paralysis versus LMN paralysis. UMN paralysis and LMN paralysis. Okay, let's discuss the difference between them. So in LMN paralysis, this is generally caused, the UMN paralysis generally caused due to lesion of pyramidal tract, as we saw earlier. Okay, pyramidal tract, and this is called LMN paralysis is due to lesion of spinal cord lesion, cranial motor neuron lesion, innervating the skeletal muscle, that innervates the skeletal muscle. These are lesions. Okay, this affect whole group of muscles, but this affect only a single muscle. Understood? UMN means up means what happened, the hypertonic muscles are there, hypertonicity of muscles are there. Okay, tone increases, so we have the spastic paralysis. What are the causes of spastic paralysis? In Guyton, two causes are given. One is the release phenomenon. What is release phenomenon? This is loss of higher inhibitory control, due to which the spastic paralysis is occurring. And another one is the denervation sensitivity. Okay, these are the two causes of a spastic paralysis. And if the element lesion, element means low means down means your hypotonicity of muscles occur. Muscles become hypotonic, means flaccid. So you have flaccid paralysis. In the flaccid paralysis, the reasons are the complete loss of muscle tone. Okay, understood? In few important characteristics of UMN lesion, LMN lesion. In UMN, clonus is present, and we have clasp knife spasticity present. And in element lesion we have fasciculations present. Hello. And in then reflexes, about reflexes, we have UMN means up means we have heightened reflexes, like the gamma motor neuron discharge increases, so we can have more reflexes, that is hyperreflexia. And here we can have the hyporeflexia. We learned about Babinski sign. In the normal sign the toes are down. Okay, in UMN paralysis the toes are going up. So going up means that is abnormal Babinski sign, that is positive. Okay, in the normal individual toes go down. So here we have positive Babinski sign, and here we have negative Babinski sign. Understood? So this completes your control of voluntary movement. Understood? And then we have the basal ganglia. Okay, another component, that is your basal ganglia. Let's talk about the basal ganglia. So in basal ganglia, it's a group of scattered masses of gray matter generally. Okay, this is a scattered group of gray matter. Okay, where it is present in the subcortical space of cerebral hemisphere. Okay, it's present in the subcortical space of your cerebral hemisphere. Let's draw the nuclei of basal ganglia. So nuclei of basal ganglia super important here, and the clinical things like hemibalism, Wilson's, Huntington's, and most important, that is Parkinson's. We have to discuss this all. Okay, so let's draw it. We'll draw like this. No, just like this. Okay, just do like this. This is your cortex. Let's say your cerebral cortex. Okay, here we have your thalamus. Okay, thalamus. So we have few nuclei here. Here we have a nucleus called as caudate nucleus, C-shaped nucleus, that is caudate nucleus. Okay, I'm changing the colors. Okay, then here you have a lens-shaped nucleus, that is called lentiform nucleus. Lentiform nucleus has three parts. One is a putamen. Okay, one is a globus pallidus externus, globus pallidus internus. Understood? The lentiform nucleus. Then another nucleus we have below the thalamus, that is a subthalamic nucleus. Understood? And then the nucleus called as your, this one is your substantia nigra. Understood? Black substance, neck grooves are there, so substantia nigra. Understood? So substantia nigra has also two parts. One is the pars compacta and your pars reticularis. Done. This is your basal ganglia. So talking about the basal ganglia, putamen and caudate nucleus. This putamen and your caudate nucleus I have drawn in this diagram, but they lie in close proximity. So putamen plus caudate nucleus, this form is striatum. Understood? This form is striatum. Okay, so what are the inputs? Of the basal ganglia? What are the inputs? One input is from the motor cortex and one input from the thalamostriate input. Okay, one input is from your motor cortex. So here must be a motor cortex here. Okay, here must be a motor cortex. So one input is from your motor cortex. Like the striatum is given input. Let's draw the striatum like this. Okay, let's draw the striatum like this. So just assume that this is your striatum. Understood? So one input is from your motor cortex, that is a positive input, and one input is from your thalamostriatal. Okay, thalamostriatal input, that is a positive. So what are the inputs from your motor cortex and one from your thalamus? Understood? What are the outputs of your basal ganglia? So one output, that is from your globus pallidus internus to your thalamus, that is an inhibitory output, and one is from pars reticularis to the thalamus. Okay, this is the inhibitory output. So what are the inhibitory outputs here? from your globus pallidus internus to your thalamus, inhibitory, and from your pars reticularis to your thalamus, that is also inhibitory. So these are the inputs and outputs of your basal ganglia. Understood? So let's now know about the role of basal ganglia. Many students confuse here. Okay, the role of basal ganglia are very super important here. So basal ganglia have to plan the movement. Okay, in planning part there are four things. Okay, so one of them was basal ganglia and another was cerebellum. We are discussing about the basal ganglia. So about planning. Okay, about the planning, let's discuss about the nucleus. What is the this shaped nucleus? What is the nucleus? Caudate. C for caudate and C for cognition. So caudate nucleus is for cognitive activities. Okay, let's discuss about at rest. Okay, what are the effects at rest? At the rest, the globus pallidus internus, which have an inhibitory input on your thalamus, this inhibits your thalamus. Okay, this inhibits your thalamus, and in turn the thalamus inhibits your motor cortex, and your motor cortex is inhibited, so no movement is there. So at rest, no movement is there. To start the movement, to initiate the movement, what happens that the globus pallidus internus, which was inhibiting the thalamus, okay, the striatum inactivates the globus pallidus internus. Okay, inactivates the globus pallidus internus, which removes the inhibitory control upon the thalamus. So thalamus is now neutral. Okay, thalamus is now neutral. To again come to rest, so thalamus is now excited. Okay, not neutral, like it will work. So there is the movement, and movement is occurring. To again come to rest. What happens to again come to rest? Your globus pallidus internus, which was inhibiting your thalamus, okay, this is excited by subthalamic nuclei. This subthalamic nuclei is the only excitatory nuclei in the basal ganglia. So it activates the globus pallidus internus, which which more inactivates the thalamus more. Okay, so the thalamus inactivates the motor cortex, and the motor cortex comes to rest. So these are the things that are occurring. So at rest, to initiate, and to again come to rest. Understood? Now let's discuss about the clinical physiology of the basal ganglia. Clinical physiology is important in the case of basal ganglia. So clinical. Let's discuss about some clinical things like what are the nucleus and injuries here. Okay, if the striatum is injured, we have a disorder called as chorea. Chorea means dancing movements. Okay, like Huntington's chorea, like this. We have a pathway from substantia nigra to the striatum. This pathway is called as a nigrostriatal pathway. If this pathway is inhibited, we have disorder called as the Parkinsonism or paralysis agitans. Okay, this is dopaminergic pathway. Then lentiform, in the lentiform nucleus, we have some copper deposition. Due to copper deposition, the lentiform nucleus, which disorder is there? Wilson's disease is there. Understood? Wilson's disease is due to copper deposition in lentiform nucleus. Understood? We learned that the striatum has an inhibitory control upon the GPE. Okay, the striatum has an inhibitory control on the GPE also. If you haven't heard about it earlier, then just hear it now. If this inhibitory control is inhibited, okay, this is blocked, then we have the Huntington's chorea. Okay, then due to the damage to putamen and globus pallidus externus, we can have a disorder which is called as your athetosis. Understood? Athetosis is due to damage to your putamen and your globus pallidus externus. Understood? And due to the damage to the subthalamic nucleus, you have hemibalism. Okay, let's go about disorders in detail. So we have first of all the Parkinsonisms, which you have to discuss in detail. Parkinson's disease, Parkinsonism. Okay, this is also called as this is a neurodegenerative disorder. Okay, James Parkinson discovered it first, so it is named after him. Okay, also called as your paralysis agitans. Okay, and the great boxer, the Muhammad Ali, was affected by Parkinsonisms due to repeated blows to his head. Okay, due to his nigrostriatal pathway is damaged. This is caused due to the damage to the nigrostriatal pathway. This is damaged. Okay, the dopaminergic nigrostriatal pathway is damaged. What are the causes of damage? So causes of damage is that viral encephalitis. Okay, viral encephalitis, head injuries. Okay, just write injuries, encephalitis. Then long-term drug use like reserpine. Reserpine is a drug. If long term it is used, then it will cause the Parkinsonism. Okay, understood? Then we have idiopathic causes also, like we don't know the cause, so idiopathic. It is also idiopathic in nature. Injuries, viral encephalitis, reserpine, and idiopathic causes, unknown causes. Like, okay. So what are the cardinal features? Well, I'm naming the cardinal features. I'm not writing the details of it. Okay, because you have to revise the whole part. Okay, so first of all, we have a tremor, which is called as a static tremor, or a resting tremor, or a drum beating. Okay, or a pill rolling tremor. Understood? This is one. Another is your slowness of movements, that is bradykinesia or your akinesia, no movements. Okay, movement is slowed down. Okay, poverty of movements. So we can have the mask-like face, mask-like or statue-like appearance. We can have a rigidity in the body, which is called as continuous. It may be continuous rigidity. Okay, continuous rigidity, which is called as your lead pipe rigidity, or your discontinuous rigidity, that is called as cogwheel rigidity. Understood? We have rigidity also. Then we have gait. Gait is called in the walking style, that is a festinant gait. Okay, and the short shuffling steps. The patient takes short shuffling steps. Then we have this like patient acts like it is chasing his the center of gravity. Okay, speech is slurred speech. That's a slurred. These are all the cardinal features of your Parkinson's disease. Okay, how do you treat it? By L-DOPA, levodopa. It can cross the blood-brain barrier and can help in treating it. Then we have the Wilson's disease. What happens in Wilson's disease? I told to discuss the rest disease in little detail only. What happens to Wilson's disease? That it is an inherited disorder. Okay, mutation is in ATPase. Might have heard in the mineral metabolism chapter also, biochemistry. ATPase 7B is mutated due to the copper is not defectively absorbed. Okay, so copper is deposited in a lentiform nucleus, LFN, lentiform nucleus, which is also called as progressive hepatolenticular degeneration. Okay, then we have a hemibalism. So ballistic, you must have heard, like gun-like movements, shooting movements, like. So this is due to the damage to a subthalamic nucleus, due to which a flinging movements occur, flinging movement, like rapid involuntary movements occur. Okay, then we have a disorder called as Huntington's disease, Huntington's chorea or Huntington's disease. Okay, What is it due to? This is due to this striatum has an inhibitory control on GPE. Okay, inhibitory control on GPE, which is damaged due to which the GP is firing at an own rate. Okay, so this occurs often like in the mid age, like 30 to 40, 50 years of age. Early signs of the early signs like jerky trajectory of hand while trying to reach a spot. Okay, the hand is jerky movements. It's a hyperkinetic disorder. Hyperkinetic movements occur. Okay, there is slurred speech, and ultimately there is your dementia also. Okay, dementia, senile dementia. Then we have chorea. Chorea is another disorder, chorea, and chorea is due to damage to striatum. Okay, damage to striatum. If the damage due to striatum damage to striatum ultimately will damage this pathway also, inhibitory control also. So most of the times that Huntington's and chorea are just related and called Huntington's chorea. Okay, so here chorea means dancing movement, like rapid, jerky, dancing type movements. Okay, with jerky dancing movements seen in complications as a result of rheumatic fever. Okay, this is called as Sydenham's chorea. We have two types of special choreas, Sydenham's chorea and chorea gravidarum. Sydenham's chorea is due to seen in the children as a complication of rheumatic fever. Okay, rheumatic fever, and chorea gravidum is associated with the pregnancy. Understood? Then we have your athetosis. Athetosis is due to a damage to putamen and globus pallidus externus. So here we have worm-like movements, writhing movements. The blue RI. Just remember this words, writhing movements. Okay, worm-like writhing movements, like fingers and wrists, they are just moving worm-like, like in Kathakali and in the Odissi dances. Okay, so this is done. Now let's go to your cerebellum. So in cerebellum is the coordinator of the body. Follows the rule of 3. What is the rule of 3 here? The cerebellum has three things. If you just see, it has three things. Okay, just I am drawing the structure of the cerebellum. So here, just a simple structure is not much good. Understood? Here like this. Okay, this is the cerebellum. So here we have a worm-like part. This one, worm-like part. Okay, this is your vermis. Okay, and this red part, is your cerebellum. This red part is your cerebellum. This red part is your cerebellum. Okay, this vermis part is your spinocerebellum. Okay, and this green part, look at this. Sorry, not green, let's take blue. This one, this is called as a flocculonodular lobe. This is a flocculonodular lobe, and this part is called as a vestibulocerebellum. Understood? So what are the functions? Vermis. What are the function of vermis? Vermis receives the plan. Not the vermis, like cerebrocerebellum and cerebro. This is cerebro. Okay, cerebrocerebellum, this receives the plan. Okay, and the vermis part, this spinocerebellum or the vermis part, this helps in your muscle movement coordination. And vestibulocerebellum, as it is evident, the flocculonodular lobe, it controls the eye movement, called as some reflex is there, which is called as your doll's eye reflex or your vestibulocerebellar ocular reflex. What is this vestibular ocular reflex? That if you move like the eyes are moved. Okay, so the neck also turns automatically, like I've seen Annabelle and all. Okay, so scary reflex like vestibulo-ocular reflex, just type it in the internet and see how head neck movement is there. Okay, so what is the functional anatomy? What are the let's discuss about neurotransmitters. What are the neurotransmitter released by cerebellum? Three neurotransmitters are there. There are GABA, okay, aspartate. Rule of three, of course. This is also three. Look, sinus, cerebello, vestibular. This is neurotransmitter also three: GABA, aspartate, and glutamate. Okay. What is the functional anatomy? Functional division of cerebellum. Okay, we can have outer gray matter. Okay, inner white matter, and your deep cerebellar nuclei. Okay, so functional classification, this is a functional anatomy. So you can write the anatomical classification. Not the anatomical, you can just specifically write the structural classification if you want. Okay, structural. The question is there. Then we have the functional classification. This is the functional classification. Look, this is the functional classification: vestibulo, cerebro, and spino. Understood? So vestibulocerebellar part is due to equilibrium, eye movement, and gait. Okay, the functions are equilibrium, eye movement, and gait movements. Okay, then your cerebellum is due to planning and coordination. Learning. Okay, planning is there also. Okay, coordination, learning, planning, and coordination. Look, here is also rule of three: equilibrium, eye, and gait, learning, planning, coordination. And spinocerebellum is comparison of plan with performance. What is a plan and how you are performing is the role of spinocerebellum, or the vermis part. Understood? This is the functional classification. Then we have pure anatomical classification. What is the anatomical classification? We have anterior lobe, we have posterior lobe, and another lobe which is called as your flocculonodular lobe. Understood? Then we have the phylogenetic classification. The phylogenetic classification have archicerebellum, we have the paleocerebellum, and we have the neocerebellum. Archi, paleo, and neo. Understood? So let's learn about the structural classification. Okay, cerebral cortex, then we have white matter and deep cerebellar nuclei. These three are the structure. Okay, so let's discuss about the cerebral cortex first. Cerebral cortex is again divided into three layers. One is your molecular layer. Another one is your Purkinje cell layer, and another one is your granular layer. Okay, so in molecular layer we have stellate cells and basket cells. In Purkinje cell layer we have Purkinje cells, which are largest neurons. Okay, these are the largest neurons. And the granular cells, we have granule cells, GG. Okay, granule cells and your Golgi cells. Understood? So let's learn about the cerebellar nuclei. Let's learn about the cerebellar nuclei. So talking about cerebellar nuclei, we have the from outer to inner. Okay, we have the mnemonic. Okay, deer eat great food. Deers eat great food. Okay, so from D, E, G, and F we have dentate nuclei. We can have emboliform nuclei, we can have your globose nuclei, we can have your fastigial nuclei. Okay, understood? These are your nuclei. So dentate nuclei helps in your planning, This all helps in your coordination. And fastigial nuclei is an additional function plus coordination plus saccades and pursuits. Saccades and pursuits. What are saccades and pursuits? Saccades means jumping eyeball movement, okay, like dancing eyeball movements, and pursuit is the continuous eyeball movement. This is a jumping eyeball movements, and this is a continuous eyeball movements. Understood? Then let's talk about the after cerebellar nuclei. We have to talk about the white matter. I'm talking about the structural classification now only. So in white matter also three types of fibers are there. One is the projection fibers. Okay. Another one is your association fibers. And another one is your commissural fibers. Understood? So talking about these fibers, let's discuss this. Projection fibers. Projection fibers are fibers which connect the superior cerebellar peduncle to the midbrain, the middle cerebral peduncle to the pons, and the inferior cerebral peduncle to the medulla. Understood? Association fibers are fibers which connect different region of same cerebellar hemisphere, different region within the cerebellum. Commissural fibers are there which connect the two half of cerebellum. This one. Two half of cerebellum are connected by commissural fibers. Understood? So what are the connections of cerebellum? This is very important. The internal circuitry of your cerebellum comes as a sort. Okay, talking about how cerebellum is internally connected. Okay, the internal circuitry. This is a very important topic. Okay, so in internal circuitry we have this nuclei called as your granule cells. Okay, here we have PC, Purkinje, stellate cells, basket cells, and your Golgi cells. Okay, this is your Golgi. This is your basket cells, stellate cells, and Purkinje cells. Understood? So granule cells, what it does, it gives excitatory feedback. It stimulates all of them. Okay, but Golgi cell is a bad cell. Okay, it doesn't want to be stimulated by some granule cell. Okay, Golgi cell wants to remove it. Okay, so it inhibits it, granule cell. This is called the feedback inhibition. Understood? Then what happens? The basket cell doesn't like the Purkinje cell. The basket cell and stellate cell both doesn't like a Purkinje cell, inhibit the Purkinje cell. Stellate cell also inhibit the Purkinje cell. Okay, this both inhibition is called as a feed forward inhibition. Understood? And this all are your deep cerebellar nuclei. Let's say it's a deep nuclei. So Purkinje cell inhibits, it gets frustrated by inhibition by stellate and basket. Okay, so it inhibits the whole deep nuclei, the whole family of deep nuclei. It inhibits. But from outside, the deep nuclei is getting positive feedbacks, positive inputs. Okay, understood? So let's see what are the positive inputs are coming from where, from the cerebellum or from the outside. Where are they coming, and which fibers are they using to come from there? Okay, so one type of fiber is called as a mossy fibers. This mossy fiber stimulate your granule cells. Moss-like fibers. Okay, so one mossy fibers connects to 1 million of granule cells. Mossy fibers less in number, so one mossy fiber stimulates 1 million granule cells. Okay, so 1:1 million. So it stimulates the granule cell. Understood? And then you have another type of fiber which is called as a climbing fibers. Okay, which enter from the inferior olive of medulla, and it also stimulates the Purkinje cells, not the granule. It stimulates the Purkinje cells. So from from where the mossy fibers arise. Okay, the point is from where the mossy fibers arise. So mossy fibers arise from, you must have heard of the game called PSM or something like that. Okay, PSM. What is P? Pons. Which part of pons? Pontocerebellar tract. S means spinal cord. Which part of spinal cord? The spinocerebellar tract, of course. M from M, midbrain, medulla, and muscles. From midbrain, which tract is there? Tectocerebellar tract. From medulla, from where? The vestibulocerebellar tract. And from muscles, the cuneo-cerebellar tract. Understand? So mossy fibers are from here, okay, and climbing fibers from inferior olives of medulla. Understood? After this, how cerebellum controls the voluntary movement. So the functions of cerebellum are important. What are the functions of cerebellum? So what are the functions of cerebellum? One is the comparator function. Comparator. It compares how is the plan and what the muscles, tendons, or the joints are doing. Another is the damping action, means prevents the exaggeration. Okay, exaggeration of movement if it's there, so it prevents the exaggeration. Okay, it prevents the overshooting. Then we have the timing and programming of movements. The timing and programming. Okay, timing and programming of movements, like the pyramidal tract, if it does some wrong thing, okay, if the movements are irregular, so it is prevented by the cerebellum. Okay, then another thing is called as the servo mechanism. It senses any disturbances in programmed movements of cerebral cortex also and corrects the movement. Okay, so this is there. Then we have some clinicals, like let's go here and talk about cerebellum and so on. If cerebellum is damaged, okay, the planning is not there. There is no planning. There is delay in initiation of movements. Okay, delay in initiation of movements. If vestibulocerebellum is injured, what is the use of vestibulocerebellum? Balance, equilibrium, and gait. Okay, balance, equilibrium, eye movements. So there is imbalance, there is disequilibrium, and there is nystagmus. Nystagmus is important. Then if spinocerebellum is damaged, then there is incoordination, that is called as ataxia. Okay, then incoordination in cerebral lesion patients. So what are the features you will observe in a cerebellar lesion patient? If a cerebellar lesion patient comes, what are the signs you will check for? So the main features are there in a mnemonic called as vanished, VANISHED. Vanished. Okay, what are the things? Vanished. First one is your vertigo. The patient will express vertigo. Okay. Second one is ataxia, difficult coordination, or called as the drunken gait. Okay, drunken gait is observed in your cerebellar lesion patient. Then N stands for nystagmus. Okay, nystagmus is there. Then I stands for intentional tremors. Intentional tremors are there. Okay, intentional tremors are there. S stands for your slurred speech. H stands for hypotonia. And E stands for exaggerated broad base gait. And D stands for dysdiadochokinesia. Okay. So after this, we have few points to remember. That is some other signs. Okay. After this, some other signs are there, like dysmetria is also there. Dysmetria Dysmetria means inability to estimate some distances. Okay, then we have intentional tremors. I told what is dysdiadochokinesia? This is inability to do alternate movements, like clapping with alternate hands, the sides of alternate sides of hands is dysdiadochokinesia, which is altered in your cerebellar lesion patients. Okay, like if you tell the patient to do so, it will just clap. And dysarthria also, that is slurred speech, that is dysarthria, and a rebound phenomenon is also observed here. Rebound phenomenon is there, and the Romberg's sign is positive. So what does mean by Romberg's sign positive? That is, the patient tends to fall in the direction where the cerebellar lesion is present, okay, by closing his or her eye. If you just make a blind, ask the patient with eyes closed to stand just erect, then the patient will tend to fall in the side where cerebellar lesion has occurred. Okay, so Romberg's sign is positive. After this cerebellum is completed, now we will see how the posture is regulated. Okay, what are the postural reflexes and how the posture regulation is done. Okay, so starting with postural regulation, okay, which is a function of your motor cortex. Okay, so posture is a subconscious maintenance of tone in relation to every movement of every muscle possible is called as posture. Okay, the subconsciously maintenance of the muscle tone in relation to the movement. So what is the significance of posture? So it increases the smoothness of movement. Okay, increases the smoothness, increases the accuracy of movement. Okay, and maintenance of center of gravity of movement, it maintains it. Okay, so what are the posture regulating mechanisms? So we have 3 posture regulating mechanism. Okay, let's talk about the medial descending tracts, which regulates the posture. We saw earlier that medial descending tracts regulate posture. We have some postural reflexes. Okay, postural reflexes from the cortex, from the midbrain, from the medulla, and from the spinal cord. Okay, and then we have muscle tone maintenance. Okay, understood? Let's talk about the medial descending tracts now. Medial descending tracts, we have which tracts? We have the medial corticospinal tract, we have the tectospinal tract, we have the vestibulospinal tract, and we have the reticulospinal tract. Medial corticospinal tract supplies the axial muscles or the trunk muscles. Tectospinal, that is superior colliculus, related to superior colliculus. Okay, which is related to eye, so it maintains the head eye movements. Vestibulospinal tract is maintenance of equilibrium, and reticulospinal tract helps in the maintenance of the extension of all 4 limbs. Understood? And then we have to talk about the postural reflexes. Okay, what are the reflexes that are postural reflexes? So from cortex we have 3 reflexes, that is the optical writing reflex, we have the placing reaction, and we have the hopping reaction. From midbrain we have around 4 reflexes, that is, first one is labyrinthine reflex, neck writing reflex. Okay, then we have body on head writing reflex, and fourth is your body on body writing reflex. Understood? Then from medulla we have tonic labyrinthine reflex, reflex and tonic neck reflex. From spinal cord we have stretch reflex and positive and negative supporting reactions. Okay, so vast majority of reflexes are there. We don't need to discuss each and every one, okay, but we have to discuss most of them and how they are responsible for maintenance of the posture. Okay, let's talk about the optical writing reflex. Like I'll give an example. Like if you just if a cat falls from your fifth floor, okay, not the fifth floor, it is more the second floor. Let's say second floor. If a cat falls like this with its limbs towards this side, okay, but as it falls, the body reflexively moves in the favor of ground, okay, and the cat lands up on its paws, okay, it lands on its paws easily. So this optical writing reflex, that is placing reaction. If an infant, okay, it is seen in infant, placing and hopping are seen in infants, okay, these are infantile reflexes. So placing reaction when the infant is held erect, okay, let's say this is an infant, if you hold it erect and the dorsum foot is drawn, let's say this is a tabletop, okay, it is hold erect and then infant is moved towards this, the edge of table is pointing like this, so the infant tends to climb, okay, tends to climb up the step, like flexion and extension of knee occurs. So this is placing reaction. What is hopping reaction? Let's say you're standing here and someone pushes you there in this direction, so you have to maintain your posture, so you just hop, like hop and just try to balance yourself, okay, you just hop and try to balance yourself. This is hopping reaction, okay. Then we have tonic labyrinthine reflex. What is tonic labyrinthine reflex? Okay, if let's say you are playing football and you're trying to catch a ball, okay, that are you are the goalkeeper and trying to prevent the ball from hitting the net, okay. So if the arms and legs, okay, tonic labyrinthine reflex means the arms and legs are extended when the head moves backward. You can see the video of tonic labyrinthine reflex if it is possible, okay, and the arms and legs are curled if the head moves forward, okay. And another thing is that if the head moves to right, then we have extension of right limbs and the flexion of left limb. Then vice versa, like if the head moves to the left, then the extension of left limb. So in which direction the head is moved, okay, the limbs are extended in the same direction so as to balance the center of gravity, okay. Understood? So after this we have to discuss this is called as the tonic labyrinthine reflex, okay. Understood? Tonic labyrinthine reflex, arms and legs are extended when head moves backward, and if head moves to right, then extension of right limb and flexion of left limb. Understood? Then we have to discuss the tonic neck reflex. What is the meaning of tonic neck reflex is that it is seen in infants, okay, it is seen in infants. So what happen in infants is that okay, so what happens in infant is that if head is moved to the right, the fencing position, and extension of the arm on right side and flexion on left side, the same thing if it is seen in infants, it is called as the tonic neck reflex. Understood? Then we have the stretch reflex, okay, we have the stretch reflex, which is a reflex of the spinal cord. What is stretch reflex? So you must have performed the knee hammer, the test of quadriceps tendon. You have tendon tap. Okay, you can have tendon tap. Tendon tap on which muscle? You have quadriceps muscle. Okay, the muscle stretches. Muscle stretches. Muscle spindle stretches. Okay, the back fiber stretches. Okay, it stimulates the 1A fiber, and 1A goes to spinal cord, and A alpha arises from spinal cord and contraction, and the muscle contracts. Okay, this is the stretch reflex. Then we have the supporting reactions, the supporting reflexes. The supporting reflexes. Okay. So we have the positive supporting reflex and the negative supporting reflex. We have the positive supporting reflex and the negative supporting reflex. Okay, so in positive supporting reflex, the flexors and extensors contract simultaneously to maintain a rigid standing posture. So positive supporting reflex is helping to maintain a standard rigid standing posture. Okay, and the negative supporting reflex is just the disappearance. Okay, this is the disappearance of positive supporting reflex. Okay, this is just the disappearance positive supporting reflex. The muscles are generally partially contracted, not completely contracted or simultaneously contracted. This is maintained by your A gamma motor neurons. Okay, that same pathway from reticulospinal tract. Pons stimulates the A gamma, medulla inhibits the A gamma. The reticulospinal tract of medulla inhibits the A gamma, which in turn stimulates the muscle spindle back fibers. It stimulates 1A, which goes to spinal cord. It gives A alpha. A alpha causes contraction of extrafusal and of the whole muscle fiber. Okay. Then we have to discuss about the muscle tone. So muscle tone was one of the thing that was there. The muscle tone maintenance. We talked about medial descending tracts, about the postural reflexes. Of course, the postural reflexes, the midbrain, labyrinthine neck, writing, body on head, body on body. These are not much important, so I have skipped it. Medulla, I have discussed tonic, labyrinthine and tonic neck, and spinal cord stretch reflex and positive and negative supporting reflex have been discussed. Okay, then let's come to muscle tone. Muscle tone is normal. Okay, and we have hypotonia which occurs in the LMN disease, and we have the hypertonia which occurs in the UMN disease. Okay, if you want to know the difference between spasticity and rigidity, spasticity means hypotonia occurs in one group of muscle, okay, but in rigidity means that hypertonia occurs in both flexor and extensor groups, Spasticity is seen in your corticospinal tract lesions, okay, and hemiplegic patients. Clasp knife spasticity is a feature, okay, in hemiplegic patients. Hemiplegic patients demonstrate clasp knife spasticity. Clasp knife spasticity is seen in hemiplegic patients. And rigidity is seen in extrapyramidal lesions. Okay, it is in Parkinsonism. In Parkinson we have two types of rigidity, that is your cogwheel we discussed earlier, and in the lead pipe rigidity. Okay, lead pipe rigidity is also seen in stiff man syndrome. Another syndrome is that is called stiff man syndrome. Okay, so lead pipe rigidity is also seen in stiff man syndrome. Understood? So UMN disease and LMN disease we have discussed. So these things are there. Now next we have some postural diseases. Okay, some postural diseases. Okay, some postural diseases. So we have your decorticate rigidity and a thing called decerebrate rigidity, in which the most common cause of decorticate rigidity is damage to internal capsule. The most common cause of decerebrate rigidity is uncal herniation. There is a reason called uncus. Okay, so there is herniation in uncus which protrudes and causes the decerebrate rigidity. In this, the cortex is damaged. Okay, the cortex is damaged. Corticospinal tract will not function. CST will not function. Then rubrospinal tract is functioning. It is present midbrain, and reticulospinal tract is also functioning. So what happens is that the upper limb will be flexed and the lower limb will be expanded. Upper limb will be flexed and lower limb will be extended. Okay, this is decorticate rigidity. And decerebrate rigidity, the most common causes are cortex is not functioning, rubrospinal tract is also not functioning, but reticulospinal is functioning. So extension of all four limbs, upper limb and lower limb, all are extended. Understood? So here we complete our postural regulation and hence we complete our motor system. Let's talk about the sensory system. In sensory system, we have to talk about the synapses first. Okay, so synapses can be of two types. We know that is chemical synapses and your electrical synapses. Electrical synapses are mainly through your gap junctions. These are fast synapses, about 5% in body. Chemical are 95%. Most of the synapses which take care of your neurotransmitters. Okay, neurotransmitters are used here. So electrical synapses are an advantage of promote a synchronous firing of a group of interconnected neurons. Okay, a group of interconnected neurons can synchronously fire. Synchronous firing. Okay, which is not possible in chemical synapses. Okay, the axon terminals, which are 10,000 to 2 lakh in numbers. Okay, these are the axon terminals. Axon terminals are also called as botons or synaptic bulbs. Okay, or your knobs, terminal knobs. Okay, these all are. Then if we just see a postsynaptic and a presynaptic membrane, here we will see some vesicles containing neurotransmitter. Okay, some neurotransmitter containing vesicles. Then we have calcium channels here. Okay, as an action potential travels, calcium enters, causes fusion of venous snares to docking will occur, priming will occur, and the neurotransmitter will be released here, and here will be the receptors for the neurotransmitter to bind. Okay, the receptor, if you see the structure, we have two parts of a receptor, that is your binding component. Okay, this is a binding component, and this is your intracellular component. Okay, here the binding occurs of neurotransmitter. Understood? Here we can see some mitochondria too. Here you can see some mitochondria. What is the function of mitochondria? That synthesis of ACH, synthesis of neurotransmitter, requires ATP which is supplied by your mitochondria. Understood? Then okay, after this we can have receptors. Receptors are mainly two types. Receptors is mainly two types, that are ionotropic, okay, and metabotropic. Ionotropic receptors have the ion gated channels. Okay, the ions are responsible for opening the binding. Okay, so we have the cationic receptors, the cation channels, and the anion channels. If a neurotransmitter that opens the cation channels, then it is called as your excitatory. If a neurotransmitter opens your anion channels, okay, then it is called as inhibitory. Understood? Inhibitory and excitatory receptor, that neurotransmitter. Okay, and we have the second messenger system for metabotropic For metabotropic receptors, we have second messenger system, secondary messenger system, and the secondary messenger system takes help of G proteins. Okay, G proteins. This take help of G proteins. So let's say we have an inactive G protein complex. So inactive G protein complexes contain GDP. So I have to, let me draw the structure directly. Okay, here is a alpha subunit, and let's draw a GDP binding site here, like this. Okay, here we have the alpha subunit, okay, the gamma subunit in red, and your beta subunit in blue, and here a GDP will be bound to it. What is this? This is GDP and 2-phosphate. Understood? This is your inactive state. This is your inactive state. So what happens if the this is the membrane? Okay, if this is the membrane, then this must be the receptor protein here. This must be the receptor protein. If the neurotransmitter comes here, okay, this is the neurotransmitter which binds here. If the neurotransmitter binds here, okay, this okay, this is a receptor protein which is G linked. Okay, this is a G protein linked receptor. Okay, this whole part, look, this whole part must be attached here. Okay, after binding of neurotransmitter, what happens, that GTP comes after binding of neurotransmitter. GTP comes and knocks off this. Okay, GTP comes with its 3-phosphate, and this removes this GTP. Okay, removes this GTP. So what happens, the following thing is formed here, like this. This is your alpha subunit which retains its form, and here there will be addition of GTP with this 3-phosphate. Understood? So this is formed, and GTP basically it removes the GDP and as well as the beta and your gamma subunits also. Okay, so beta and gamma are removed. What is the function? This is the activated G protein complex. Okay, activated G protein complex. This is the activated. What is its function? It has 4 function. Okay, it has 4 function. The first function is that it opens up the calcium, the potassium channels. Okay, potassium channels. It opens up the potassium channels, which causes the potassium to leak out. Okay, it causes the potassium to leak out. Then it activates membrane enzymes. Okay, then it activate intracellular enzymes. It activates intracellular enzymes also, and activates gene transcription also. Okay, understood? So these are the function of the activated complex. So inactivation, what are the steps in inactivation of this? So GTP, the GTP bound to this, it hydrolyzes the GTP, change into GDP plus PI. Okay, so alpha subunit releases the target protein and binds to the beta and gamma again. This is the beta which will bind again, and this is your gamma which will bind again. So this again becomes inactive. And thus the secondary messenger system is inactivated. Then we have to discuss some neurotransmitters here. So neurotransmitter, we have some small rapidly acting neurotransmitter, and some your slowly acting neurotransmitter, which are also called as the neuropeptides. Understood? Neuropeptides. So we have 4 classes of this: class 1, 2, 3 and 4. Okay, so in class 1 we have ACH, acetylcholine. Okay, we have ACH. So ACH is a neurotransmitter which is secreted from where? From the pyramidal cells of motor cortex. Look here above, that we discussed when we discussed the corticospinal tract. Here It arises from motor cortex. We have some cells called as the cells of Betz. Okay, these are this type of pyramidal cells which are called as cells of Betz. Okay, these large cells are present. So it also releases acetylcholine. Okay, cells of Betz releases acetylcholine. Okay, this is done. Then we have to discuss another from where acetylcholine is also released from your basal ganglia neurons. Basal ganglia neurons. Okay, motor neurons innervating skeletal muscles. Then it is releases from preganglionic of PNS, of ANS, preganglionic of ANS, and the postganglionic neurons of PNS and SNS. Okay, these are the parts from which acetylcholine is released, and it is an excitatory neurotransmitter. Understood? Then second class comprises of amines. What are the amines? We have epinephrine, norepinephrine. Okay, we have the epinephrine, norepinephrine, dopamine and serotonin. Epinephrine, norepinephrine, dopamine and serotonin. Okay, so what do you know about epinephrine? Epinephrine and norepinephrine. Okay, these both are the stress hormones. So about norepinephrine, the special point is that it is released from locus ceruleus. It is from locus ceruleus of pons. The pons has a region called as the locus ceruleus. It is released from there. Okay, so norepinephrine is released from locus ceruleus of pons. Then we have dopamine is released from nigrostriatal pathway. We saw earlier nigrostriatal pathway. Okay, and dopamine is usually inhibitory neurotransmitter. Okay, nigrostriatal pathway and inhibitory neurotransmitter. Then serotonin about you know the chemical name, the 5-hydroxytryptamine, 5-hydroxy tryptamine. This is also a neurotransmitter. And about class 1 is ACH, class 2 is amines, class 3 is amino acids. What are the amino acids? That is your glycine, that is your GABA, glutamate and your aspartate. Okay, glycine, GABA, glutamate and aspartate. So about glycine is glycine is the simplest amino acid, S. Okay, S from spinal cord. So it is released from your spinal cord in the synapses in spinal cord, and it is also inhibitory neurotransmitter. GABA is also inhibitory. It is released from GABA is released from SCB medical cause we have. Okay, SCB. So what is SCB? S stands for your spinal cord, C stands for your cerebellum, and B stands for your basal ganglia. Okay, and the glutamate is secreted in the cerebral cortex. Okay, secreted in the cerebral cortex, and it is also an inhibitory neurotransmitter. Serotonin acts as an pain pathway. It is used in the analgesic pathways. Okay, then we have nitric oxide. So nitric oxide is not preformed and stored. It is instantly secreted. Okay, and released, so it doesn't alter the membrane potentials much. Then we have the neuropeptides. We discussed about the small rapidly acting neurotransmitters. Then we have to discuss about the neuropeptides here. Okay, so let's discuss about the neuropeptides. So what do you know about neuropeptides? That it is synthesized by the neuronal cell bodies. Okay, cell bodies, and it is synthesized by your ribosomes. Okay, the ribosomes secrete the neuropeptides. Okay, and they reach the tips of the nerve fiber by axonal streaming. Okay, axonal streaming is the way by which the neuropeptides reach the tip of the nerve fibers. Okay, so they are synthesized by your cell body, then they enter the spaces between ER, go to ER, then go to Golgi. In the Golgi there are modifications like get fragmented and get packaged. Okay, they get packaged and fragmented and they released into cytoplasm. Okay, they are released into cytoplasm, and the cytoplasm they move to the end by axonal streaming. Next we have to discuss what are the neuropeptides present. Okay, so many neuropeptides are present. Neuropeptides, many examples you can write. All the hormones. Okay, let's talk about the GIT hormones which are neuropeptides. All the GIT hormones, which one do you know? The gastrin, the BIP, UCCK. Okay, these all are. Glucagon is a neuropeptide. Okay, then we have the releasing hormone TRH, LHRH, GnRH, GHIH. Okay, ACTH, alpha MSH, LH. Okay, the posterior pituitary hormones like prolactin, not prolactin is the anterior pituitary hormone. This is prolactin. Okay, this is a vasopressin, a posterior pituitary hormone like vasopressin and oxytocin. Some other substances like enkephalins. Okay, then your leucine, your substance P. Okay, then your insulin, glucagon and all, pancreatic hormones. Okay, neurotensin, this all. Okay, understood. Next we have to talk about the potentials. Okay, next we have to talk about the potentials. If I want to talk about the potentials, so a resting neuron has minus RMP of minus 65 millivolt. Okay, if there is hyperpolarization occurs due to the Cl minus entry or the K plus efflux, hyperpolarization. So RMP goes to more negative side, that is minus 70 millivolt. Okay, the membrane potential is minus 70, and if you have your that is called minus 70, this is called IPSP, inhibitory postsynaptic potential. This occurs in the influence of your inhibitory neurotransmitter. Okay, and hyperpolarization, and then we have your depolarization, that is EPSP, action potential generation, EPSP. So in EPSP the potential goes from minus 65 to minus 45. It becomes less negative or more positive. It increases. So this occurs, EPSP occurs due to excitatory neurotransmitter. Okay, understood. So after this occurs in the due to the influx of sodium influx. Okay, IPSP occurs due to potassium efflux, and EPSP occurs due to sodium influx. Understood. After this we have the presynaptic inhibition are done by presynaptic inhibition is done by your Ranso cells. So what are Ranso cells? Ranso cells are basically the inhibitory interneurons found in the gray matter of spinal cord. Okay, so these are Ranso cells. We have the special characteristics of synapse. The first thing is the unidirectional. It is unidirectional. Okay, unidirectional. Then the second thing is the fatigue. Synaptic fatigue. The synaptic fatigue is beneficial because if no synaptic fatigue will occur, if synaptic fatigue will not occur, it will result in epileptic seizures or epilepsies. Okay, epilepsy. Then we have the effect of pH. Okay, if the pH increases, the neuronal excitability increases. If pH decreases, the neuronal excitability decreases. So in alkalosis excitability increase. In acidosis, the neuronal excitability decrease. Okay, then we have the hypoxia. Due to hypoxia there is nerve damage. Okay, the neurons are inexcitable. Okay, hypoxia decreases excitability. Then some drugs are there, some drugs like present in common substances like your caffeine is present in your coffee, and your theobromine is present in your tea, and the theophylline is present in your tea. Theophylline is present in your tea. Theobromine is present in your cocoa. Okay, so these drugs, they increase neuronal activity. Okay, sorry, excitability, not activity. Understood? Anesthetics, they increase the neuronal membrane threshold. So synaptic delay is of 0.5 millisecond. Okay, this is used to calculate the number of neurons in series, number of neurons in series in the circuit. Okay, it's a statement of Guyton. And convergence and divergence, we have summations. Okay, we have summations are of two type. We have spatial summation and we have some temporal summation. Spatial and temporal summation. So talking about spatial summation, we have two or more than separate presynaptic potentials this arrive. Okay, and terminate at a single postsynaptic end bulb. This is called spatial summation. When stimuli appears at synapse rapidly, okay, one synapse is there, second, third, fourth, fifth, the stimuli are appearing in a rapid succession. Stimuli are appearing in a rapid succession. This is called temporal summation. We have spatial summation and we have temporal summation, which completes our summation topic. Okay, then we have a small topic called as a subliminal fringe. Okay, we have a topic called as subliminal fringe. So what do you mean by subliminal fringe? Subliminal fringe. So what do you mean by subliminal fringe is that neuron receiving excitatory input. Okay, let's suppose the neuron A is receiving 10, neuron B is giving a response of 10. Okay, but A plus B, they stimulate some neurons in their periphery. Okay, peripheral neurons are stimulated, due to which the response increases. So A plus B is not 20, it is like equal to 22. Okay, so neuron receiving an excitatory input can affect synapses in its fringe or periphery. Okay, this is subliminal fringe. Then we have occlusion. What do you mean by occlusion? Occlusion means when two adjacent neurons are given stronger excitatory inputs. Means A, let's say 10, B, let's say 10, but A plus B decreases, not equal to 20, it decreases to 17. So what happens here? That overlap of excitations, the excitations when overlap, they decrease. Overlap excitation, they lower input. Okay, they produce lower input. So this is called as occlusion. Then we have types of neurons. So neurons can be of two types. One is called as the Golgi type 1 neurons. Okay, type 1, which have short axons, and we have the Golgi type 2 neurons, which have longer axons. Okay, axons. So the cortical inhibitory neurons are the Golgi type 1, and in your cortical motor neurons are the Golgi type 2 neurons. Understood? Docking, process by which vesicles attached to membrane. Priming, process by which vesicles become ready to discharge their contents in response to the stimulus. Understood? Then we come to your receptor part, the receptor physiology. Receptor physiology is also important. So we have receptor physiology to revise. Receptor physiology. Okay, so in receptor physiology, what are the pathway? Let's say we have a sensation, it travels by receptors, it goes to peripheral sensory nerves to the dorsal root ganglia to spinal cord to the thalamus, and thalamus to your sensory cortex. Okay, what is a dermatome? So dermatome is a specific part of body supplied by a particular nerve. Okay, so in spinal cord we have a law called as Bell-Magendie law. We have a law called Bell-Magendie law. So what it states that the dorsal side of spinal cord deals with sensory reception. Okay, sensory signals, carry sensory signals, and the ventral side of spinal cord it receives motor signals. Okay, it receives motor signals. Understood? This is the Bell-Magendie law. Let's talk about the spinal cord and the laminae, which is called as the next laminae. Okay, let's talk about the next laminae. I'm drawing half the spinal cord here. So let's say this is the half of the spinal cord here. Okay, this is supplied by the 10th nerve. Okay, up to this is supplied by the first, second, third, fourth, fifth, and sixth nerves. Okay, this whole part is supplied by 7, this whole part is supplied by 8, and this part is supplied by the 9th nerve. Okay, so the motor lamina, this is the motor lamina, this whole part, this is the motor lamina. Motor lamina is supplied by your 9th nerve, and the sensory lamina, this whole part. Okay, this is a sensory lamina. Which is supplied by the 1 to 6th nerves. Okay, and this two parts, this contain interneurons. This part and this part, this contains interneurons. And the part supplied by the 10th nerve, this one, it is called as intercommissural lamina. It's called as intercommissural lamina. So we have now receptors. To discuss. What are the receptors? We have a classification called as the Sherrington's classification of receptors. Sherrington's classification. So according to Sherrington was called as the father of neurophysiology. And Sherrington won the Nobel Prize for discovering the function of neurons. He defined the term synapses and gave a important law which is called as the law of reciprocal innervation. It's called the law of reciprocal innervation. Okay, so Sherrington. So according to Sherrington's classification, we have extroceptors, we have introceptors. Okay, we have proprioceptors. Understood? Introceptors, extroceptors, and proprioceptors. Extroceptors may be of two types, like somatosensory, which carry the sensation just over the surface of the body, and the telereceptors, which carry the information from far away. Somatosensory, like your touch, pressure, okay, pain, temperature, vibration. The somatosensory sensations. Telereceptors stimulates takes responses from vision, hearing, and smell. Understood? Then introceptors sense the body's intrinsic stimuli. Okay, intrinsic stimuli, like your BP from baroreceptors, O2 and CO2 by your chemoreceptors. Okay, then your osmoreceptors are there, and your visceral pain sensation is taken up by nociceptors and all. Okay, then proprioceptors, these are two in number, that is your muscle spindle, and your Golgi tendon organ, GTO. Muscle spindle and your Golgi tendon organ, which sense the position of the body. Okay, in the 3D space, or in spatial arrangement of the body in the space. Okay, then we have the classifier receptors on the basis of on OTBO stimuli type, stimuli type. Okay, receptors OTBO stimuli type. Which type of stimuli you are applying? Based upon this, the receptors can be of 6 types. One is the mechanoceptors, mechanical stimuli like touch, temperature, vibration, hearing, okay, BP and balance, okay, these all. Then thermoceptors. We have 2 types of thermoceptors, like your cold receptors and either warm or hot receptors. We'll discuss about a bit later. Then third, we have chemoceptors and the chemical stimuli, that is O2, CO2, smell and taste. Understood? Then we have fourth, osmoreceptors. Osmoreceptors, you know, body's osmolarity and sense to that. And we have nociceptors which sense pain, okay, sense pain, respond to pain stimuli. And then we have electromagnetic receptors, okay, sense the light energy and generate an action potential. Let's discuss about tactile receptors. Tactile receptors are receptors which are present in the skin, okay, they are present in the skin. So in tactile receptors, we can have 2 tactile receptors which are present in the epidermis, just inside epidermis, present inside epidermis, and some are present deep. Inside epidermis, 2 are present, that is Meissner's corpuscles and your Merkel's disc. Okay, and deeply 2 are present, Ruffini endings, and second one is your Pacinian corpuscle. If you see a Pacinian corpuscle, it looks like this, is an onion like, okay, receptor, and Ruffini endings are just like nerve endings, and Pacinian corpuscle is just deeply present and responds to pressure changes, okay, and Merkel disc is disc like as the name suggests and all. So these are some things. So let's talk about Meissner's corpuscles. So you can see there are 2 S here. So S means smooth, sounds like smooth. So it will respond to fine touch and slow vibrations. Merkel's K means crude, KRUDE, crude. So it responds to crude touch. Then Ruffini endings R means rotation and response to touch, response to stretch. What is rotation? Rotation of joints, okay, joints rotation are sensed by the Ruffini endings. And Pacinian corpuscles, P means pressure, that is deep pressure, and vibrations, that is fast vibrations. Deep pressure and fast vibrations are sensed by the Pacinian corpuscles. Understood? Then we have the adaptability of the receptors, okay, P and M, the Pacinian and your Meissner's, these are your rapidly adapting. What happens in rapidly adapting receptor, that if you give the first stimuli, response is there, second stimuli no response, third stimuli no response, no further response, okay. But in rest all, except the Pacinian and Meissner, rest all, these are called as the slow adapting receptors, So in that first response is there, second response is there, third response is there, okay, understood? Then we have to talk about a concept which is called as a receptive field. So talking about receptive field is that the field around a receptor, which by giving stimulus elicits a response. Okay, let's say here is the receptive field. Okay, is the receptive field of a receptor. Okay, so if a receptive field is there and you just stimulate here, okay, give a stimulation here, then you can get a response. You stimulate here, you can get a response. Okay, so receptive field is like that. So receptive field may be small in some cases and it may be large or diffuse in some cases. Okay, it is small in your Meissner and Meissner's and Merkel's. It is large in your Ruffini and Pacinian. Just observe that the receptors are present just above, in the diaphragm, in the epidermis, sorry. So they have small receptive fields, but the receptors are present deeply, they have large receptive fields. Okay, so stimulation within the receptive fields elicits the sensation. In thermoreceptors, I said that we have some warm and cold receptors. This cold receptors and warm receptors. The cold receptors sense temperature less than 25 degrees Celsius. Warm receptors sense temperature more than 25 degrees Celsius. Okay, if the temperature is more than 45 degrees Celsius, the pain fibers are stimulated. That is thermal nociception. That is called thermal nociception, thermal pain. Okay, some examples are the cold receptor. I am writing here cold receptor. Example is TRPM8. This is a menthol receptor. Okay, and example of a warm receptor, a hot receptor, that is TRPV124. TRPV124. These are the vanilloid receptors. Vanilloid. Okay, understood? So cold receptors and warm receptors. After this, okay, then we have a principle which is called as a labeled line principle. That is called as a labeled line principle. The labeled line principle. What is the labeled line principle? That every nerve tract ends on a specific part of CNS. Okay, every nerve tract ends on a specific part of CNS. Means from a specific receptor. Okay, if you take the impulse, they carry specific modality. Okay, and have specific termination also. Example, the pain fibers are stimulated. So only pain sensation is taken, not other sensation, and stimulates only where the pain fibers are stimulated. Okay, like retinal fibers are stimulated, they carry vision sensation also, not touch sensations. Okay, understood? So this is called as a labeled line principle. Then a concept is called as a generator potential or receptor potential. Receptor or generator potential. So what is meant by receptor generator potential is that let's say here is a Pacinian corpuscle here. Okay, here is the initial segment. Okay, this is the first node of Ranvier. Where myelination is there, here also myelination is there. Okay, this is the first node of Ranvier. So here let's say we apply some pressure. You know that Pacinian corpuscle is sensitive to pressure, so there will be a deformation. Due to this deformation, what happens, that sodium starts influx. Okay, there is the influx of sodium ions. There is an influx of sodium ions. Okay, sodium start influxing. So the membrane is depolarization. Pressure causes depolarization, and depolarization travels here, and at the first node of Ranvier, it converts into the action potential. So action potential is the first node of Ranvier. This is important. But if the action potential in where? In sensory neurons. Okay, and we are talking about sensory neurons only. In motor neurons, or normal neurons, the action potential from where it starts from the initial segment. Why? Because number of sodium voltage gated channels are more in the initial segment. Understood? but in your sensory neurons, it starts from first node of Ranvier, that is the site. Okay, then we have the properties of receptors. Some properties of receptors are there, some properties are there. Let's discuss the properties of receptors here. Okay, so properties of receptors, it is specific. One receptor is specific for one signal. Pain receptor is sensing the pain, temperature receptor is sensing the temperature, etc. So for specific, we can have a doctrine, that is Muller's law of doctrine of specific nerve energy, or Muller's law of doctrine of specific nerve energy. Muller's law of doctrine of specific nerve energy. Then we have adequate stimulus. Adequate stimulus means for rods and cones, adequate light must be given. Okay, then we have a property called as the adaptation of receptors. Okay, receptors are adapted, or it is called as the sensory adaptation or denervation. Not denervation, desensitization. Okay, adaptation or desensitization. Understood? Then we have a law called as a Weber-Fechner, Weber-Fechner law. So Weber-Fechner law states that the sensation felt is directly proportional to the log of the intensity of stimulation. How much you stimulate, the more you stimulate, the more sensation is felt. Just that is a log of intensity of stimulation. This is called as the Weber-Fechner law. This is important. Okay, understood? So after this Weber-Fechner law, we have another things. Okay, the law of projection. We have the law of projection. Before discussing law of projection, so we have a phenomena called as a phantom limb phenomena. Okay, let's say a patient has his leg amputated, right leg amputated, but he complains to the doctor that he is having pain in his amputated leg. Okay, so doctor is astonished, but he reads about the law of projection, the phantom limb phenomena. The cause of phantom limb is the cortical plasticity. Okay, if you want me to explain cortical plasticity in easy terms, then let's say here is your cortex. Okay, here's the cortex. Here is a vision area for vision, and here is the area for art and music area. Vision and art and music area. So let's say the vision area is not utilized. Okay, in a blind person. So its vision area projects to the art and music area, which is called law of projection. So it projects to art and music area. So it's the fact is governed from that many blind people are great musicians or artists. Okay, so this is called as the cortical plasticity. The cortical plasticity, which is the newer explanation to explain the phantom limb phenomena. Okay, so here phantom limb phenomena, pain felt in the amputated part. Okay, question is that like bug crawling sensation is sensed by which? The bug crawling is an example of fine touch, and fine touch is sensed by Meissner corpuscle. Understood? Adaptation, what are the things that are involved in the adaptation of receptors? Okay, adaptation of receptors. Another law I have left, that is the law of power. Okay, the law of power. What is the law of power for a receptor? Is that the law of power states that the intensity of stimulus is directly proportional to the strength of stimulus. How much strength is the stimulus, the intensity felt is more. This is the law of power. Okay, let's talk a little bit about the adaptation of receptors and how it occurs. Okay, adaptation of receptors and how it occurs. Talking about this adaptation, Like if you give a continuous stimulation, okay, the impulse rate through afferent nerve fibers can go on decreasing. Okay, like four mechanisms are there for adaptation. Okay, four mechanisms. First one is a reorientation of receptors, of receptor structure. Okay, the receptor structure can reorient. Example in Pacinian corpuscle. Pacinian corpuscle. Okay, then another thing that can occur is your dark adaptation, which occurs in rods and cones. Okay, then another adaptation is a central adaptation, which occurs in olfactory pathway. And another thing is a recruitment. What do you mean by recruitment? Is that the strength of stimulus if the strength of stimulus increases, then the more receptors are recruited. Okay, this is also an example of adaptation. That means that for example, if a war is going on, then the government tries to recruit more soldiers, more men, by training them. Okay, so as to win the war. So if the stimulus strength increases, the enemy strength increases, then more armies recruited, that is more receptors are recruited. Okay, understood? And inhibition, receptors are inhibited. So receptors are inhibited by some fibers called as efferent fibers, that are called as corticofugal fibers. Okay, they can modify the sensitivity. Okay, so this is about all about the receptors. Okay, and now we come to the sensations that the tracts are carrying. Okay, so we are basically talking about ascending tracts. So in ascending tracts, first we will talk about the sensations. Okay, sensations may be primary sensations and secondary sensations. Okay, secondary sensations are also called as your cortical sensations. Primary sensations are many, like they have their specific receptor, for them, but cortical sensations don't have their specific receptors with them. Like primary, fine touch. Okay, fine touch, pressure, vibration, proprioception, joint position, crude touch, itch, pain, temperature. Okay, do you see all? Understood? Then secondary, the cortical sensations, they have four main cortical sensations which have no receptors. Okay, and four are important. First is tactile localization. Then this is the ability to touch and locate. Tactile means touch, and localization means locate. Okay, then 2-point discrimination. Okay, 2-point discrimination. We have stereognosis. That is the ability to touch and identify an object. If someone gives a banana, then you can touch and say that it is a banana. Okay, then we have graphesthesia. Understood? So these four are your cortical sensations. Understood? So let's talk about tracts now. So in tracts, we have two major ascending tracts. That is a dorsal column tract. First, dorsal column tract, and second tract is a spinothalamic tract. Dorsal column tract and the spinothalamic tract. So talking about the dorsal column tract carries what sensations? It carries fine touch, vibration, proprioception, joint position, and all cortical sensations. What are cortical sensations? Like your 2-point discrimination, your graphesthesia, your tactile localization, and your stereognosis. Understood? All your cortical sensations. Okay. Spinothalamic tract carries only crude touch, itch, pressure, pain, and temperature. Pain and temperature are carried by your spinothalamic tract. Itch and pressure also, and crude touch are carried by your spinothalamic tract. Okay. So if I give an overview of the tracts, okay, just know about the neurons. Okay, just know about the neurons. So we have three type of neurons: first order, second order, and third order. Just importantly to memorize that second order neurons that arise at the point of decussation. There is crossing. Where there is crossing, the second order neurons arise from there. Okay, let's talk about the pathways, and first we are gonna talk about the dorsal column tract. Dorsal column tract. So it is an ascending tract. So I am taking the section like this. We know sensory cortex, like in sensory cortex 1, 2, 3, 4, the Brodmann area, sensory cortex 1, 2, 3, 4, 5, 6, 7 are there in total, but 1, 2, 3, 5 and 7, these are sensory. Okay, so in dorsal column tract we have a sensory cortex. Let's start from below. Okay, here we have our spinal cord. This is a pretty spinal cord over here. Understood? What's there to understand? Okay, let's start. So we have sensations, skin sensations. What are the sensations carried by dorsal tract? That is fine touch, that is your many others were there, right? Fine touch, your vibration, proprioception, joint position, 2-point graphesthesia, your stereognosis, tactile discrimination and all. Okay, tactile localization and all. So skin sensations, these are taken by your peripheral nerves. Okay, let's say this is a peripheral nerve going over here like this and going up like this. Okay, let's say this is the midline of the body, this is the midline of the body. Okay, another fiber is going from here, taking the skin sensations, going here and going up. Okay, this is also there in the medulla. Okay, let me draw the section of medulla. So here you have the medulla here. Let's say here you have the medulla. Okay, in the medulla, this both they terminate, this terminates and this also terminates. Okay, from here origins another decussate here like this, and this also decussate here like this. Okay, then we have the thalamus over here. This is a thalamus, so it terminates here and this one also terminates here, and from here this gives to your sensory cortex over here. It also gives to your sensory cortex. This is a sensory cortex, the Brodmann's area 1, 2, 3, 5 or 7. Brodmann's area 1, 2, 3, 5 or 7. Understood? So what I have to learn, this is a dorsal root ganglia over here, this is a DRG. The skin sensations are traveled by the peripheral sensory nerves. Okay, traverse the peripheral sensory nerves. Okay, and they go up, and here we have the fasciculus cuneatus, the red one that is lying laterally. Okay, this is called as the fasciculus cuneatus. This is present laterally. It carries sensations from upper limb. Okay, this is very important. And then we have, it is also called as the tract of Burdach. BURDACH, tract of Burdach. And in the medial side, the blue one, this one we have, this is called as a fasciculus Gracilis. So gracilis, you know, is a muscle of lower limb. Okay, the medial component of your thigh, medial aspect of the thigh muscle is a gracilis. So it runs medially. Okay, carries sensation from your lower limb. Okay, sensation from lower limb, also called as your tract of gull. Understood? This is the tract of gull. So fasciculus unit is called the tract of Burdach, and this is called as the tract of gull. Understood? This goes up, and here we have two other nucleuses, and this is called the nucleus cuneatus, NC nucleus cuneatus. This is called as the nucleus gracilis, terminates over here, and from here what arises from here, this the yellow highlighted part are the second order neurons. Why I told like this? The level at which they cross, okay, at the level that they cross the decussate, that is a point from which second order neurons arise. Okay, and these all are the third order neurons. Okay, this not just this. Okay, this is a third order neuron. Understood? So after you understood this all, let's go there. Okay, another thing I wanted to tell. Okay, this is the midline that is present here. Okay, this pathway, as it crosses to the medial side of the body, this pathway, this whole part, like look at this, this both combinedly are called as your medial lemniscal pathway. Understood? The medial lemniscal pathway. So after this, let's talk about the disorders of the dorsal column tract. Okay, so disorders are important. If you get a long question on dorsal column tract, then you will draw this diagram, explain some things about the dorsal column tract, and then we'll write some disorders also. Okay, so disorders are you should mention, because marks are given for writing clinical things very well. Okay, let's say there is a disorder in the peripheral nerves. The peripheral sensory nerves are damaged. Okay, peripheral sensory nerves are damaged. This is a level 1 injury. If this happens, the peripheral sensory nerves are damaged, then what happens? Okay, if this like in which things the peripheral sensory nerves may be damaged? In exotomy, in demyelination, like in distal sensory neuropathy. Okay, in ischemia, like, okay, and in compression, like compressive neuropathy. In compressive neuropathy have many examples, like most important example is the carpal tunnel syndrome. Because it's a carpal tunnel syndrome. Understood? This is your peripheral sensory nerve damage. Understood? Then at the level of dorsal root ganglion, if damage occurs at level of dorsal root ganglion, the DRG is damaged. At the level of DRG, what happens is that, like in herpes infection, okay, many disorders are there at the level of DRG. So let's discuss it. Let me number it. Okay, it will be easy. So peripheral sensory nerve damage is number 1, which I already discussed. This all cases. Then DRG damage is number 2 damage. Okay, at the level of DRG. Let me mark it with red so that it gets not confused. 2. Okay, at the level of your dorsal column. Okay, this part at this level, let's mark it with number 3 damage. Okay, level 3 damage. Then at the medial column pathway, damage here, it is level 4 damage. Okay, and damage to sensory cortex is damaged in level 5 damage. Okay, so we have 5 damaging criteria. Okay, so second one, disorders of DRG. So what are the disorders of DRG? Like herpes infection, the herpes zoster virus. Okay, in herpes infection, it stays in DRG. Okay, after chickenpox is recovered, the herpes virus stays in DRG for 10 to 15 years. Okay, it is immunocompromised. But if reactivation is there, then herpes zoster is caused. So herpes infection generally disrupts the DRG. Okay, then another thing is a cisplatin. Cisplatin is an anti-cancer drug. Okay, cisplatin is an anti-cancer drug. So side effect is that it destroys the side effect. So it destroys the your DRG. Okay, then what happens? So vitamin E antioxidant activity is also prescribed along with cisplatin to prevent it. Then NAV 1.8, this is voltage gated sodium channel. Okay, the blockers of NAV 1.8 also blocks pain, but it damages the DRG. This also damages the DRG. Then we have some other things like lidocaine and mexilatin, which can damage the DRG also. Okay, third is the damage disorders of the dorsal column disorders. Okay, here we can have many disorders. Okay, many disorders. We can have tactile agnosia, inability to touch and perceive objects. We can have SACD, that is subacute combined degeneration. Okay, so dorsal column and lateral column both are damaged. Okay, so we can say that subacute combined degeneration, or it is also called as Lichthims disease, or Putnam-Dana syndrome. Lichthims disease or Putnam-Dana syndrome. Then we can have your diabetes mellitus, very common diabetes mellitus. Okay, in diabetes mellitus, your vitamin how the diabetes mellitus is damaging the dorsal column tract is that the vitamin and the diabetes mellitus, the first line of drug is your metformin. Okay, the first drug that the physician prescribes is a metformin. Okay, it's a metformin. So what happens is the metformin is the first line of drug. It blocks vitamin B12 absorption. Okay, it blocks vitamin B12 absorption. Understood? So if vitamin B12 is deficient, if it blocks vitamin B12 absorption, okay, then methionine synthesis is blocked. Okay, and methionine is required for myelination. So loss of myelination occurs. Okay, vitamin B12 is not absorbed, so methionine synthesis is blocked, and methionine is required for your myelination. So myelination is not occurred, and due to myelination not occurred, dorsal column is blocked. Okay, then we have dorsal column damage, that is in tabes dorsalis. Okay, tabes dorsalis, that is a complication of syphilis. Then we have sensory ataxia. Then we have PCS, posterior cord syndrome, and syringomelia. Tabes dorsalis and syringomelia are commonly given in your textbooks, and other are just extra things in medicine. Okay, so tabes dorsalis, that is occurred in syphilis, and syringomelia, that is fluid filled cavity around the spinal canal, like this is the spinal cord. Okay, so if fluid filled cavity occurs around your spinal cord, which grows anteriorly. Okay, which grows in the anterior direction, so that it compresses. So it compresses your dorsal column is compressed, and if dorsal column is compressed, then it will just damage it. Okay, then we have disorders of thalamic disorders. Okay, in thalamic disorders we have some thing called as thalamic pain syndrome. Thalamic pain syndrome. Thalamic pain syndrome, which is also called as a Deserine Rosy syndrome. Deserine Rosy syndrome. Okay, thalamic pain syndrome. Understood? Then we have the disorders of sensory cortex. Sensory cortex disorders. Sensory cortex disorders. Okay, sensory cortex disorders. We can have 3 sensory cortex disorders present. That is, first one is the tactile agnosia. Second one is the paresthesia. And third one is the amorphosynthesis. So what is the meaning of 3 terms, new terms? Tactile agnosia is the inability to touch and perceive sensations. Okay, inability to perceive sensations. Okay, so a person can't perceive sensations. Okay, it can't perceive sensations. Paresthesia are abnormal sensations of the body. Okay, and amorphosynthesis is the hemi neglect of the body. Okay, that's a hemi neglect of the body. Like if damage to right sensory cortex is there, the patient will neglect the left side. Okay, hemi neglect will occur in contralateral direction. So if it is the damage is occurred, the damage to right sensory cortex, damage to right sensory cortex, then the left side is neglected. So what the patient does is, patient tends to wear the slippers, clothes, or shaves beard only on right side. He neglects the left side of body as if there is no left side existing in his body. Okay, so here we completed our dorsal column tract. Then we have the pain physiology. Okay, what is pain? So pain is an important topic in your CNS. So let's talk about the pain physiology. Let's talk about the pain physiology. So what is pain? Pain is a physical adjunct of an impending tissue damage. Okay, it is an unpleasant sensation, but it associated with actual or potential tissue damage. Either it may be associated actual tissue damage, maybe tissue damage has occurred and pain is occurring, or it can indicate a potential tissue damage that is about to occur. Okay, it makes one aware of danger, makes the person to react and remove the pain stimulus, and it has protective function. Okay, so for pain we have receptors called as nociceptors. Okay, respond to noxious stimuli. Okay, these are non-adapting receptors. What are the fibers carrying pain? The fibers carrying pain are called as A delta fibers and C fibers. A delta and C fibers, these are the fibers which carry the pain. Okay, so pain can be physiologically, the qualitative types of pain are of 2 types. Okay, the pain can be of 2 types. One is a fast pain and one is a slow pain. Understood? Fast pain and your slow pain. So fast pain is a sharp localized pricking type of pain. Okay, it's a sharp and localized pain carried by A delta fiber. Slow pain is a dull throbbing, less localized pain. It persists and it is dull. Okay, little pain per sitting for a long time. It is carried by the C fibers, C type of fibers. Understood? It applies it appears within 0.1 millisecond of applying of stimulus. Okay, after applying of stimulus, 0.1 millisecond within it starts. Okay, and it appears after 1 second of applying of stimulus. Okay, what are the responses in the fast pain? So fast pain in the responses, so response are withdrawal. Okay, like a pin is pricked. Okay, so you just withdraw the finger. Okay, before or just after picking the pin. Okay, and we have sympathetic response. These are the responses. For slow pain we have autonomic response, and have decreased muscle tone. Okay, autonomic response and decreased muscle tone. These are the qualitative qualitative classification. Then we have the pain types depending upon the clinical types of pain. Clinical types of pain. What are the clinical types of pain? So we have the somatic pain and the visceral pain. Somatic pain and your visceral pain. So somatic pain means it can have two types, like the superficial somatic pain and the deep somatic pain. Okay, and visceral pain arises from your internal organs, okay, as in abdominal viscera. Okay, so let's talk about these types of pain. So talking about these types of pain, okay, this type of pain can be like somatic pain, superficial somatic pain. The features are similar to the fast pain, okay, but this arises from a skin and your superficial fascia, okay, and these are physiologically, these are like fast pain. These are fast pains. These are just the sharp pricking pain and such. Deep somatic pain arises from the deep fascia, and it has features similar to the slow pain. Understood? Then comes visceral pain. Visceral pain arises from the internal organs, abdominal viscera. It is poorly localized, okay, and autonomic symptoms are there. Autonomic symptoms like your nausea is there, vomiting, okay, depression, this all. And it features that is called as guarding. What is guarding? Guarding is the reflex contraction of abdominal muscles. They reflexly contract. Reflex contraction of abdominal muscles causes the is seen in the visceral pain. Okay, what are the examples of visceral pain? Examples of visceral pain may be appendicitis, okay, cholecystitis. Then we have spasms, colics, okay, like colic pain, uterine pain, is all. We can have the chemical stimuli for visceral pain, and we can have ischemia. Okay, this is all responsible for your visceral pain. Okay, this is all responsible for your visceral pain. Appendicitis, cholecystitis, spasms, colics, uterine contractions, chemical stimuli like gastric acids. Some acids may cause the pain, and ischemic responses. Okay, then we have perception. So pain is perceived in nociceptor component and affective component. Okay, affective nociceptor component occurs at subcortical level, but affective component, it involves connection between spinothalamic and limbic system. So it is the cognitive component of pain. Okay, there's an emotional response, that is affective component of pain. Okay, we'll talk about the spinothalamic tract in a while and allogenous substances. Okay, so let's talk about the perception of pain, which I was saying a second ago. Okay, perception of pain. So pain is perceived in two components, that is your first component, that is the nociceptive component of pain, and another is the affective component of pain. Okay, so nociceptive component occurs at subcortical level. Okay, it occurs at subcortical level, and the affective component, it involves emotions, like how you are just taking up the pain. Okay, like emotional connections, cognitive component, and the attention component. This is attention component. Attention component means that if you just pay much attention on a small wound, it starts paining more. Okay, if you focus on pain, the perception of pain increases. So this is the affective component of perception of pain. Okay, so we have pain pathways. To carry pain, generally we use our pain pathway, that is spinothalamic tract. That is a spinothalamic tract. Okay, so we'll talk about the spinothalamic tract, about the fibers. Okay, so spinothalamic tract has two type of fibers, that is your A delta fibers and your C fibers. Okay, let's see how they are going. So I am drawing the spinal cord here. The spinal cord, this is also an ascending tract, of course. So here we have A delta fiber. A delta fiber is reaching there, decussating here and moving upward. Similarly, the C fibers, these are going here, decussating here and moving upwards. C fibers are giving some branches, mostly they are giving some branches like this. Okay, understood? So these two pathways, these are called as your spinothalamic tract. Okay, so red one is a delta, and the blue one, let's take it in this blue. Okay, this is your C fibers. Let's talk about A delta and C in detail. A delta, what pain is carries? It carries fast pain. Okay, which is the localized pain, needle prick, electric shock. Okay, which neurotransmitter it uses? It uses glutamate. Okay, important. A delta uses glutamate as neurotransmitter. Okay, but C fibers, what they carry? They carry your slow pain or diffuse pain. Okay, and example like visceral pain. Okay, they carry visceral pain also. Neurotransmitter is used as glutamate plus substance P. Important. Neurotransmitter glutamate plus substance P in C fibers. Okay, so A alpha is done, C alpha is done. Okay, A delta pathway, this red pathway, A delta pathway, this whole red pathway is also called as a neospinothalamic tract. Okay, this is called as neospinothalamic tract. And then your C fibers, this C pathway, this pathway is also called as a paleospinothalamic tract. Understood? So neospinothalamic, this is a paleospinothalamic tract. So after you understood this, let's move forward and discuss about some algogenic substances. Okay, substances that are released at the site of injury and mediate the pain. Okay, mediate pain. The substances mediate pain are called as algogenic substances. And the algogenic substances, that many examples are there. Okay, many examples are there. So you can just remember BHAPs, BHA, BHAP, PS. Okay, BHAPs. So first one is a bradykinin. Okay, H is your histamine. Bradykinin is the most important. Okay, histamine. Then your acids, acetylcholine, your acids. Then prostaglandin and your serotonin. Prostaglandin and proteolytic enzymes also. And your serotonin. These are your algogenic substances. Mnemonic is BHAPs. Okay, BHAP means smoke, so BHAPs. Okay, so this algogenic, after the algogenic substances, let's move to your referred pain. What is a referred pain? What is referred pain or reflective pain? This is also called a reflective pain. Example of referred pain, like in myocardial infarction, the chest pain is referred to the tip of left shoulder and left arm. Okay, so referred pain. So two theories for referred pain. One is the dermatomal theory and the second one is your convergence projection theory. Your dermatomal theory and your convergence projection theory. Okay, so what are these theories? So let's talk about your dermatomal theory. And according to dermatomal theory, okay, let's say this is a dermatome, a specific dermatome over here. Okay, this is a specific dermatome. So it's taking that to the heart. We're taking this example only, the myocardial infarction. There's a heart pain which is terminating in this dermatome, and there is the pain of your tip of the shoulder which is also terminating in this dermatome. So if the fibers are terminating in the same dermatome, okay, so the pain in one region can be referred to the another region, or the pain in another region can be referred back to the heart. Okay, this is a dermatomal theory. Another is the convergence projection theory, which says that both fibers converge at the same second order neuron. Okay, both fibers converge at same second order neuron. Okay, they converge at the same second order neuron. So if here is the second order neuron, let's say this one, this is a second order neuron. So and this is a person, okay, and this is a heart. So the pain from heart comes from here, okay, and from here also, but from this two, it is taken up by the same second order neuron. It is same from both, same for both. Okay, it is taken up by the same second order neuron. Then we have the pain inhibiting systems, the exogenous pain inhibiting systems. Okay, so I hope you are not exhausted now. Okay, so it's exam time and I just need to revise, so just I'm making the video at night for you only. Okay, so I hope you are not exhausted and energy is left. Yeah, so let's start again with the same energy as I started earlier our lecture. Okay, keep on making notes, keep on hearing the things and looking from books. Okay, so let's start with exogenous pain inhibiting systems. Okay, pain inhibiting systems, pain inhibiting systems, which are called as your your analgesic pathways. Three pain inhibiting systems are there. One is the mesencephalic pain inhibiting system. Third is the opioid system, and the third is a gate control theory. Understood? These three are pain inhibiting systems. So discussing about the first theory, the mesencephalic. Okay, it starts at PAG. What is PAG? PAG is a periaqueductal gray matter. Okay, it starts at here. Okay, PAG starts at PAG, descends down to an area called as LC. What is LC? Locus ceruleus. Non-epinephrine secreting neurons are present here. Remember, yeah, it is present in the pons. Okay, further descends down to the NRM and RBLM. What is NRM? NRM is the nucleus raphe magnus, and RLVM is the rostral ventrolateral medulla. Okay, and then it descends down to the spinal cord. Understood? And descend down to the spinal cord. Okay, then stimulates the inhibitory interneuron. If inhibitory interneuron is stimulated, it inhibits the pain pathway. Okay, It inhibits the pain pathway. If I just draw a simple diagram to show this, let's draw this. Like I should not do this. This is a PAG present, okay, in the midbrain. This is the pons, and this is the medulla oblongata. This is a PAG. This is the pons, and this is the medulla. Okay, so it starts from here, descends down to the pons, locus ceruleus of the pons, descends to the medulla where NRM and RLVM, RVLM, rostroventral medulla. Okay, and descends down, and here is the spinal cord. It terminates in the inhibitory interneuron. Inhibitory interneuron inhibits the pain pathway, and the pain pathway that goes up in the thalamus, it passes through BPL of thalamus and the sensory cortex. Okay, this all are inhibited. This is a mesencephalic pain inhibiting system. And second one is your endogenous opioid system. Okay, endogenous opioid system. Some opioid things are there. Opioids are there, like which are released endogenous opioids. Endogenous opioids are released by the inhibitory interneuron only. So released by the inhibitory interneuron. Like example is enkephalin. Okay, then your endorphins, and dynorphins. Enkephalins, endorphins, and dynorphins are your endogenous opioids. Okay, so these are released by the inhibitory interneuron. Okay, and some other opioids are exogenous opioids are heroin, morphine, codeine. What are they? They are exogenous opioids. Okay, so what's the function? Endogenous opioids are same thing. Look at this. I'm drawing the endogenous opioid system in green. So what happens is that the inhibitory interneuron, this inhibitory interneuron, this starts producing the opioids. It produces the opioids, and pain pathway is there. So opioids, what do? They decrease the pain. Okay, decrease the pain, and thus the pain is decreased. Easy. Next thing is the gate control theory. So this is a function of A beta fibers. So studies say that A beta fibers, they close the pain gate. So there is a thing called with pain gate, and this is closed by the A beta fibers. Okay, A beta fibers close the pain gate. Understood? So if you do some massage, okay, do some massage or spa or some spa techniques. Okay, so A beta fibers are stimulated, and A beta fibers, they close the pain gate, and the pain fibers, they close the pain gate, so pain cannot travel via this pathway, and so this is just removed. Okay, then we have a thing called as transcutaneous electric nerve stimulation TENS. It also stimulates the A beta fibers. And this also decreases the pain. This is an recent advance. Some terms are there like algesia term means pain. Okay, hyperalgesia means increased pain perception. Hypo means decreased pains that perception. Analgesia is the loss of pain. So this is the analgesic pathways, as I told earlier. The analgesic pathways, the pain losing pathways. Okay, then we have asthenia. One is the asthenia. So asthenia is the all sensations, including pain. Okay, so causes of causalgia means unknown cause. Okay, burning pain occurs like in long back or nerve injuries. Okay, in neuralgia means pain along nerves, like trigeminal neuralgia is there. And neuropathic pain, okay, due to known cause like central neuropathy or diabetic neuropathy. Okay, this all. So these are just some few terms, and pain physiology is completed now here. Okay, then we have the thalamus. Okay, then we have the topic, a small topic called as your thalamus. Okay, thalamus is the main relay center. Thalamus what is it? It is a relay center. Okay, it is the relay center, and thalamus is sensory relay center. Except olfaction, all sensations pass through the thalamus. The olfaction doesn't pass through the thalamus, rest all pass through the thalamus. Okay, so if I just draw the structure of the thalamus is important. Okay, here we have two main things, that is your internal medullary lamina. This is internal medullary lamina. Okay, and this is a lamina. Okay, so here we have group of nucleus. Look at this. This is your anterior group, this is your medial group, and this is your lateral group. Okay, this whole part is your lateral group. So in lateral group we have many parts, like this is your pulvinar part. Here we have a body called as a medial geniculate body. You have a body called as your lateral geniculate body. Here is lateral geniculate body. Okay, and this part, lateral group of nucleus, is divided into another two parts, the LP, LD, BP, VI, VL, BM. Okay, not BM, BA. Understood? So and the BP is again divided into BPL and BPM. Okay, so these are the parts and things which are important. Okay, dorsal, so dorsal group and ventral group are there. Okay, dorsal group and ventral group are there. So this whole part, the pulvinar, the LP and LD, this whole part, this is your dorsal group. Okay, this is your dorsal group. This is your dorsal group, and the second part, this one is a ventral group. Okay, dorsal group and a ventral group, these are important in the case of thalamus. Okay, so what are the functions? Okay, what are the functions? So let's take here. Okay, let's check out there is a formation, reticular formation in this the medullary lamina, the internal medullary lamina. Here you have reticular formation, thalamic reticular formation. Thalamic reticular formation, it is useful for coordination, as well as it produces GABA. Okay, the anterior group, the first group, the anterior group are useful for emotions. Anterior group are useful for your emotions, the memory and the learning. Okay, emotions, memory and learning. Okay, understood? LP and pulvinar, this two things, the pulvinar as well as the LP, this help in the vision pathway. Okay, this help in the vision pathway. Another thing is the VL and VA, this help in the motor pathway. Okay, motor functions, in the motor functions. Understood? Motor functions is there. Then another thing is the BPL and BPM. Okay, BPL and BPM. So BPL is very, let's take a mnemonic, that is very painful limbs. So it carries pain sensation, pain from limbs, pain and other through from limbs. Okay, and BPM is very painful mouth. Okay, So it carries pain and other sensations from mouth and face. Understood? Carry other sensation from mouth as well as face. Then we can discuss the functions of MGB and LGB, medial geniculate body. M for music. Let's say it's M for music. So music means MGB has used in auditory pathway, and LGB means L for stands for light. Okay, and LGB it is used in light, and it is used in the visual pathway. Used in the visual pathway. Understood? Understood. After this, we can have some thalamic syndrome. Okay, some thalamic syndrome. Let me ask a question. Okay, there is a 12-year-old boy who has his forehead. His forehead has a cut. Okay, laceration or cut. Through what thalamic nucleus is pain relayed to the primary sensory cortex? Through what fibers? So what thalamic? No, not fiber. What thalamic nucleus is pain relayed? So cut forehead. Forehead belongs to the face, and the face pain sensations are from face. The pain sensations are carried by whom? The very painful mouth. The BPM. The BPM nucleus is the answer. Okay, these are some of the important questions. Let me state one clinical, that is thalamic syndrome. Thalamic syndrome. Let me teach you the thalamic syndrome. Okay, thalamic syndrome refers to causes the most common cause. The most common cause is the blockage of geniculo, not the geniculo, thalamo geniculate branch of posterior cerebral artery. Okay, thalamo geniculate branch of posterior cerebral artery. Signs. What are the signs and symptoms? It can have sensory symptoms as well as motor symptoms. Okay, what are the sensory symptoms? There is stereognosis. So stereognosis property is absent. There is thalamic phantom limb. There is thalamic phantom limb. There is thalamic overreaction. Thalamic overreaction. Okay, thalamic overreaction. Understood? Then we have motor symptoms. We have ataxia, and we have involuntary movements. Then we have thalamic hand, which is also called as athetoid hand. The hand is an abnormal posture, like the thumb is like this, the index finger is like this, and other fingers are like this. Okay, the abnormal posture of hand, like Dracula type posture of hand. Okay, moderately flexed wrist with hyperextended fingers. Okay, the wrist is moderate flexion. Okay, moderate flex, and the fingers, the phalanges, are hyperextended. Understood? Done. So this we complete about thalamus, and now we come to some other things. Okay, that is the about the other chapters, like your hypothalamus. Let's come to hypothalamus first. Okay, then we'll cover other things like speech, sleep, and other important the interesting chapters are there. Let's finish the hypothalamus. Very little thing are there. Okay, hypothalamus is called the head ganglion. It's called the head ganglion of the ANS by some scientist, which is Serrington called as the hypothalamus the head ganglion. Okay, the master endocrine gland is also it's a hypothalamus. Okay, what are the afferent connections of the hypothalamus? From where hypothalamus receives its input? Hypothalamus, what are the connections? It receives from fornix It receives from stria terminalis. Okay, it receives from medial forebrain bundle, from palido hypothalamic fibers, from cortico hypothalamic fibers, from reticulo hypothalamic fibers, and from thalamo hypothalamic fibers. Understood? So these are the connections, inputs of the hypothalamus. What are the, these are the afferents. Okay, what are the efferents? Let me mark the efferents in the same diagram only. Okay, I'll light with red. Okay, what are the efferents? Mammaliothalamic fibers. It gives out mammaliothalamic fibers. Which goes from the mammillary body of hypothalamus to the thalamus. Okay, then we have mammiliotegmental fibers. Okay, which goes from mammillary body to the tegmentum. And we have the paraventricular fibers. Brainstems, which go to the brainstem, spinal cord, and cortex. Okay, thalamus cortex. And then we have hypothalamo hypophyseal tract also, and hypophyseal tract. Understood? What are the functions of hypothalamus? First, it controls the pituitary. Functions: controls the pituitary. Okay, releases the releasing hormone. Okay, then hypothalamus releases produces oxytocin and ADH. It produces oxytocin and ADH, which is stored in the posterior pituitary. Okay, hypothalamus has nuclei also. It has some nuclei also. What are the nuclei of hypothalamus? Okay, so it has many nuclei. Some nuclei, let me just enumerate. So hypothalamus has anterior, posterior, lateral, and medial part. Okay, anterior, posterior, lateral, and medial part. So anterior portion of hypothalamus, let's think of a car. Okay, anterior portion of a car means it's the engine is what it does. Okay, engine gets heated, so hypothalamus will cool it, just cooling. And the posterior part is your heating of body, just cooling of body. Okay, then the lateral part is is the feeding, the thirst. Okay, the feeding and the thirst. The medial part is satiety, the anger. And think of a passenger who is sitting in the back side of a seat. Okay, the back of the car. Okay, this is the car and this is the that things. Okay, here is a person, here's the door, here's the door. Okay, the person can easily get out and buy some food item and eat. Okay, so lateral part is feeding. Okay, feeding a thirst. But the medial part here, he has satiety. Okay, he can't go out, so he has anger also. Okay, he's aggressive, so this is aggression. The middle part cannot get out of the car, the middle person, so he has anger. And then nuclei. In nuclei we have arcuate nuclei, we have suprachiasmatic nuclei. Okay, and two other nuclei which are written with mnemonic SOAP. So SAPO. What is this? Let me enumerate. S means your supraoptic nucleus, which produces A is ADH, okay, and your P means paraventricular nucleus, which produces O means oxytocin. Understood? S and P, what it produces, okay. Then arcuate nucleus, what is the arcuate nucleus? This helps in feeding, okay, increases or decreases feeding. Suprachiasmatic nucleus has a role in circadian rhythm of the body, okay, circadian rhythm of the body. These two nucleus are done. The mammillary body helps in the memory processes, okay. And then we have the preoptic area also, preoptic nucleus or area, which regulates the blood pressure and heart rate, regulates the BP and heart rate. It decreases the BP and heart rate, okay. So this is done. So let's discuss how the anterior hypothalamus cools the body, or the posterior hypothalamus heats the body, okay. The thermogenesis and all, the lateral hypothalamus, and the what are the nucleus, the ventromedial nucleus, lipostatic theory, glucostatic theory, okay, about the arcuate nucleus, suprachiasmatic nucleus, and the clinical pathology, that is hypothalamic syndrome, okay. Let's discuss all this. So talking about anterior hypothalamus, so first let's discuss the action of anterior hypothalamus. Anterior hypothalamus has a role in the cooling of body, okay. So anterior hypothalamus actually what it does, cools the body, okay. So what it does is that if there is, it also regulates the osmolarity of body, okay, the concentration, osmolarity, thirst and all, okay, the thirst centers and all, these are also regulated by your anterior hypothalamus. So what happens if there is hypovolemic shock is there, hypovolemia is there, so blood volume decreases, so baroreceptors are stimulated, and your angiotensin it is also stimulated, which increase the thirst, okay, it increase the thirst, so volume becomes normal. So dryness also increases the thirst, which elevates it. Metering also increases the thirst, okay. Then we have hypertonicity means that your blood is more concentrated blood, okay. It also stimulates the osmoreceptors, and it also stimulates your thirst, okay. So thirst centers of hypothalamus are two thirst centers are there. One is the subfornical organs and OVLT means organum vasculosum lamina terminalis. These are devoid of blood-brain barrier, okay, this is an MCQ. So after this, posterior hypothalamus heat production, okay, posterior hypothalamus has the function of heat production. Heat production is called as the thermogenesis, okay, it's called as thermogenesis. 37 degrees Celsius, okay, this is the normal body temperature, it falls to 36 degrees Celsius, okay, less decrease. This is non-severing thermogenesis, okay. But further fall like below 36, or further fall like 35.5 degrees Celsius, it causes severing thermogenesis. It's called as severing thermogenesis, okay. So what are the causes of severing and non-severing thermogenesis, okay. Why we don't sever here? Non-shivering thermogenesis in adults, in children. So in adults, it is due to the use of sympathetics like epinephrine and norepinephrine. Okay, and thyroid hormones and eating. This is all. In children, this is due to the brown adipose tissue. Okay, shivering thermogenesis, it is the production of shiver. Okay, so lateral hypothalamus, the function lateral hypothalamus. This is the hunger center. Okay, this is the hunger center. So it produces hunger. And the medial hypothalamus, it produces satiety means the sense of fulfillment. Okay, so lateral hypothalamus, what it does, it produces orexins. What it produces? Orexins or your hypocretins. What are the substances? The orexins or hypocretins, what are the substances that example of an orexin, is ghrelin which stimulates the hunger. Okay, stimulates the hunger. And also responsible in this orexins, hypocretins are also for wakefulness. Okay, if this orexins and hypocretins are not synthesized, wakefulness won't occur and it will lead to narcolepsy. What is narcolepsy? Excessive daytime sleepiness. Okay, excessive daytime sleepiness is called as your narcolepsy. Understood? Okay, so this is done. Then your your satiety center, that is your medial hypothalamus. Okay, that is your medial hypothalamus. What is how it starts? Satiety center. So how satiety is brought about? So we have two theories. One is the lipostatic theory and one is called a glucostatic theory. Lipostatic theory is that satiety is brought about by a hormone called leptin. Okay, it's a hormone produced by adipose cells. Adipose cells have produced a hormone which is called as a leptin. Okay, it's a proteinaceous hormone which stimulates the VMN, the ventromedial nucleus, and which decreases the food intake. So it produces satiety. Okay, so leptin mediated lipostatic theory. And glucostatic theory is that adequate supplies of adequate glucose supply. Due to adequate glucose supply, some glucoreceptors stimulates the glucoreceptors. Okay, and glucoreceptors that's cells of satiety. These glucoreceptors are basically the cells of satiety center only. Okay, cells of satiety center. So this is the satiety. Okay, understood? Okay, so now let's move to your arcuate nucleus. Arcuate nucleus, this increases feeding or decreases feeding. This increases feeding by releasing neuropeptide Y and your agouti related peptide. Okay, and decreases feeding by releasing alpha MSH and your CART. What is CART? CART is your cocaine and amphetamine regulated transcript. Understood? Cocaine and amphetamine regulated transcript. Understood? This is CART. After arcuate nucleus, we have a nucleus called as suprachiasmatic nucleus. This regulates the circadian rhythm. circadian rhythm. Okay, like if there is darkness, it is sensed by your retina senses the darkness. Okay, stimulates the suprachiasmatic nucleus gives stimulates the pineal gland. Okay, pineal gland stimulated, pineal gland secretes melatonin, and melatonin is called as a sleep hormone. This is melatonin also responsible for the fertility purposes. Okay, this is important to note. Okay, then we have sleep disorders also. In sleep disorders like transient sleep disorders and chronic sleep disorders, we'll see in sleep. So we give melatonin supplements to sleep. So melatonin supplements are given examples like ramelteon and zolpidem. Ramelteon and zolpidem are your melatonin supplements. About clinical physiology, we have an hypothalamic syndrome. First type is the global hypothalamic syndrome, and second is the partial hypothalamic syndrome. How does global hypothalamic syndrome occur? Okay, it has many causes like your primary tumors, metastasis, lymphomas, and sarcoidosis. Okay, primary tumors, cancers, lymphoma, and the sarcoidosis. Due to the global, the whole hypothalamus fails. Okay, the whole homeostatic mechanism, this all fail and the patient dies. Okay, dies. This is very difficult to live with this phenomenon. Okay, then partial, what happens in partial? The selective lesions. Let's say if the ADH is lesioned. Okay, ADH is lesioned, what will it cause? It will cause diabetes insipidus. If the ADH is increased, it will cause SIADH. What is SIADH? Syndrome of inappropriate ADH secretion, or neurogenic salt wasting, as it is called. Neurogenic salt wasting. Okay, and if GnRH is increased, then what will occur? Precocious puberty. If lateral and medial hypothalamus is lesioned, the body weight is altered. Okay, and hypothalamic cardiovascular disorders may occur. Like it depends upon the region of hypothalamus that is injured. Okay, so with this we complete our hypothalamus too. Okay, and now let's go to the language and speech areas. Okay, language and speech. Let's talk a little bit about language and speech and how the language and speech are produced, articulated. What the Broca's aphasia, Wernicke's aphasia, arcuate fasciculus, and stuttering. What is prosopagnosia and acalculia? Okay, let's talk about this. So let's talk. Okay, before discussing the language and speech, I have left a topic. Okay, let's discuss the topic first, then we'll come to the language and speech, because it is the part of the higher functions. Language, speech, and sleep, etc. we'll discuss. First, let's discuss the limbic system. Okay, limbic system. Interesting, right? Limbic system is located on the temporal lobe of the brain. Limbus means a ring. Okay, a ring type of structure. Okay, these parts of cortex, this comprise of the cortex parts and some subcortical regions also. Okay, subcortical structures which form a ring around the brainstem. Okay, this was previously called as the smell brain or rhinencephalon. Smell brain or your rhinencephalon. So let's talk about the diagram. Okay, that's an easy way to draw the diagram, which I always follow, is that just first of all, draw two seahorses which are reading under a bulb. Okay, first draw a bulb. Okay, and name it olfactory bulb. These are the radiations of the olfactory bulb. Okay, and draw two seahorses here, like first seahorse and its tail over here like this. Okay, and the second seahorse I draw here, it's like this, and let's draw it with another color so that it's get prominent. Let me draw it like this, and the tail is going a little bit like far, coming here only. Understood? So there are two seahorses lying down. Okay, and C is there. There's the C, and above it also is the C. Okay, understood? So this is our structure of the limbic system. Let me label it. Okay, olfactory bulb is labeled. Okay, these are the radiations, three radiations: MOT, the Broca's, let me label this tracts. As this is an olfactory bulb, so the medial olfactory tract from here. Okay, the diagonal band of Broca, here you have a lateral olfactory tract over here. Okay, three are there. These two structures, there's the head of the two seahorses, this form the amygdala. Okay, amygdala. This is the hippocampus. Okay, this is the this one is the stria terminalis, and this one is the fornix. Okay, fornix. This is the midbrain. This is the hypothalamus, and here we have the thalamus. Okay, and here we have this one is the, in which color should I write? Yes, corpus callosum, and this one is the cingulate gyrus. Okay, understood? So you draw the two structures. Okay, then not much things are there in this limbic system. One thing that is commonly asked in the limbic system is the Pepez circuit. Okay, PAPEZ, Pepez circuit is the internal circuitry within the limbic system. So how it is connected? Look at this. Okay, so the first thing that is pointing in green. Okay, the hippocampus gives a arrow. From hippocampus give a arrow to mammillary body. Hippocampus to mammillary body is connected. Mammillary body to your thalamus. Okay, mammillary body to your thalamus is connected by this arrow. Thalamus to the cingulate gyrus by this arrow. Thalamus to the cingulate gyrus, and cingulate gyrus again to hippocampus by this arrow. Okay, cingulate gyrus again to your hypothalamus by this arrow. Okay, this is the Pepez circuit, and in this Pepez circuit, let me just write easily that hippocampus to mammillary body to thalamus, and thalamus to cingulate gyrus, and cingulate gyrus again to hippocampus. This is a Pepez circuit, and this Pepez circuit importance is that it just connects the limbic system. Like within the limbic system, the functions of limbic system can be associated. Okay, the memory can be associated with your functions of emotions and memory. Okay, and the déjà vu and jamais vu, this all phenomena are due to this Pepez circuit only. Okay, so amygdala is called as the window of limbic system. It connects the limbic system to outer parts. Okay, outer parts of brain. What are the functions? of limbic system? So hypothalamus. The functions, let me write here only. Hypothalamus. Many functions: temperature regulation, hormone control, the hormones that are synthesized, okay, the nuclei, the body temperature regulation, okay, many functions are there. Hippocampus is the consolidation of memory. Hippocampus helps in hippocampus helps in the consolidation of memory. Okay, hippocampus is in the consolidation of memory. And in your in short-term memory, the short-term memory to a long-term memory conversion is done by hippocampus. Their olfactory bulb is helping in olfaction. There is olfaction. Olfaction means smell, okay. And amygdala is helping in emotions. So connection of that hippocampus and amygdala is important also. The emotions and memory are connected, okay. Emotions is the aroused state involving intense feelings, autonomic manifestations, and its related behaviors. Emotion, let me talk about emotions a bit, okay. Many are emotional, like, okay, emotional people. Emotions, so it has a mental component and there's a physical component also, okay. Mental component means is a cognition, which recognition of a thing which is happening, okay. The affect is the development of the feeling. Cognition is the recognition, affect is the development of feeling. And conation is the force which directs some response, okay, like a bomb blast, okay. Cognition is recognition of bomb blast, affect is the feeling of afraidness, and conation is the yelling or trying to run, okay. The physical component or expressive component is the motor component, expressive component. It has also somatic component, or your autonomic component. Two components of this. And somatic component means the changes in the muscle changes, okay. Skeletal muscle undergo few changes, this come under the somatic component, okay. The autonomic component means it has sympathetic component and your parasympathetic component, sympathetic and parasympathetic component. Sympathetic component, and heart rate increases, bp increases, okay, respiratory rate increases. Parasympathetic, all gland secretions increases and dissolve decreases, okay. Understood. Some clinical aspects are there, like if two phenomena that is called as a deja vu. Like, have you ever felt like already perceiving a thing which appears before you for the first time? Like, you go to a new place, but you go on in your mind that I have visited this place earlier also, okay. So this is called deja vu. And second one is a Jamais vu. So Jamais vu and deja vu. Jamais vu means that a sudden feeling of sitting in a strange place, okay. A strange place, like if you are in your house, but suddenly you feel like you are sitting somewhere else and you don't know the place, or you are sitting for the first time and all. So deja vu and Jamais vu, these both phenomenon are prominent, is seen. These are just physiological also, but pathologically these are prominently seen in a disorder called as medial temporal lobe epilepsy. Okay, prominently seen in medial temporal lobe epilepsy, okay. Understood. So in medial temporal lobe epilepsy, what happens? The uncus, hippocampus, and the amygdala, all three are damaged, okay. So the memory and emotions, these are mixed, okay. It's mixed and generate a new type of signal. So deja vu and this Jamais vu occur, okay. Another in clinical, another thing I have to discuss is the Kluver-Bucy syndrome. The Kluver-Bucy syndrome. Kluver-Bucy syndrome is due to the bilateral damage of amygdala. Okay, so if the amygdala here, this amygdala is damaged, okay, is bilaterally damaged, it will cause Kluver-Bucy syndrome. Kluver-Bucy syndrome. So what happens in the Kluver-Bucy syndrome is that in Kluver-Bucy syndrome, okay, in Kluver-Bucy, this is a bilateral damage to amygdala. Okay, bilateral damage to amygdala, and due to this, the emotions like the fear and sexual behavior. Fear is decreased and sexual behaviors are increased. So there is no fear and there is hypersexuality. Okay, and due to no fear, patient is hypermetamorphosis. Hypermetamorphosis means that the person is just like a kid and does all sorts of mischief without any fear, like very dangerous things without any fear. Okay, that is Kluver-Bucy syndrome, that is caused due to bilateral damage of your amygdala. Now comes your language and speech. So language and speech are the higher functions of the brain and very developed in humans. So mechanism related to language is mostly localized to your neocortex. Okay, mostly localized to your neocortex. Language is the understanding of the spoken and printed word. Okay, and expressing the ideas in speech and writing. You understand a thing and you can express in speech or in writing. Okay, old concept was telling that we have a dominant hemisphere and non-dominant hemisphere, and dominant hemisphere was concerned with some categorization or symbolization, and non-dominant was with spatio-temporal relations. But a newer concept, we have a categorical hemisphere. We have a categorical hemisphere. Which is for sequential analytical processes, and we have a representative hemisphere, which is for your visuospatial relations. Understood? So in right-handed individuals, your left hemisphere is the categorical hemisphere. Okay, in the in right-handed, okay, in 96% cases, this data are from directly from your Ganong textbook. Okay, the latest edition of Ganong. Okay, 96% of cases, your in right-handed, the left hemisphere is categorical. Okay, left hemisphere is your categorical hemisphere. Okay, let's talk about some terms like astereognosis. What is astereognosis? This is the inability to identify objects just by feeling them. Okay, you give a object like a pen to someone, and with his eyes closed, and he can't feel the he can't tell if it is a pen or not, like from feeling. Okay, then we have agnosia, a term called agnosia. This is the inability to recognize object by a particular sensory modality. Okay, like just by seeing he can't identify, just by seeing. Okay, just by hearing he can't identify, but if he combines hearing and seeing, okay, he can identify the object. Okay, so leaving all this, let's talk about the physiology of language. Okay, so let's see which areas we have for language. Okay, so here is our cortex, cerebral cortex. Okay, here we have the Broca's area. Where it is located in the front of inferior end of motor cortex that is in the frontal lobe. The frontal lobe, this is the Broca's area. And then we have an vernix area too. Here is the vernix area. So vernix area. Vernix area. Where is the vernix area located? At the posterior end of superior temporal gyrus. Okay, posterior end of superior temporal gyrus, and the fibers that are connecting the two major centers for speech, this one is called as the arcuate fasciculus. Okay, vernix area projects by arcuate fasciculus to the Broca's area. Understood? Okay, so let's trace the pathway of your speech. Okay, let's see the pathway of your speech. So let me draw a cortex like this. Okay, neat diagram of the cortex. Okay, first of all, here we have what we have here is a lateral geniculate body. Okay, from lateral geniculate body, the signal comes to your primary visual cortex. Okay, write in red. Okay, here is the primary visual cortex. Primary visual cortex. It goes to here. Okay, this is the area called as your higher order visual cortical area. This primary visual cortex is area number 17. There is a higher order visual cortical areas. Like area number 18. Okay, from here it goes to your angular gyrus. Angular gyrus, that is area number 39, Broadman area 39. And from angular gyrus it moves to your vernix area. This is a vernix area, that is area number 22. And from vernix area via the arcuate fasciculus it moves to your Broca's area. Understood? So this 5 number, okay, it goes to the Broca's area. This green pathway, what is this? Just identify it. Yes, it is the arcuate fasciculus. Understood? And from the Broca's area, it goes to the facial area of motor cortex. The facial area. Why it goes to the facial area? It will do the appropriate movement of the lips or the tongue, okay, to speak, to produce the speech. This is the area, facial area is area number 4. Understood how it's going? Okay, how it's going. So let me trace the pathway again. So from lateral geniculate body, which is responsible for vision, okay, it goes to the primary visual cortex. From primary visual cortical areas, this is area number 18, this is area number 17. Okay, from primary visual cortical areas it goes to angular gyrus, this is area number 39. Angular gyrus to vernix area, which is area number 22. Vernix to arcuate fasciculus to Broca's area, and Broca's area to facial area of motor cortex, that is area number 4. Okay, and this produces speech. Understood? So this is your speech pathway. Okay, then we have to discuss the aphasias. Okay, language disorders, that is aphasias. So aphasias are language function caused by lesions in categorical hemispheres. Okay, the most common cause is the thrombosis of a cerebral blood vessel. Thrombosis of a cerebral blood vessel. Okay, let's say cerebral blood vessel thrombosed, then it will cause the aphasias. So aphasias may be of three types. One is non-fluent aphasia, one is non-fluent, one is the fluent aphasia, and another was the anomic aphasia. Non-fluent, fluent, and anomic aphasia. So non-fluent aphasia is called as the motor aphasia or non-express or expressive aphasia. Expressive. This is due to Broca's area lesion, damage to Broca's. Okay, Broca's, damage to Broca's. Then here what we have, that slow speech is there, and words are difficult to generation. Okay, generation is difficult. Okay, in fluent aphasia, the speech is normal speech, but full of jargons and nonsense speech. Okay, nonsense speech. The person says a lot of things, but it doesn't make any sense. Okay, this is due to Wernicke's area, the lesions of Wernicke's area. So this is also called as the sensory aphasia. Non-fluent or motor aphasia due to Broca's area lesion. Fluent or sensory aphasia due to Wernicke's area lesion. Okay, and then your anomic aphasia due to the lesion of angular gyrus. Due to which no speech difficulty. Okay, no difficulty in understanding also, but the trouble in understanding written language or pictures. Okay, no difficulty in understanding the auditory info, but the things that are written. Okay, the things that are written or the pictures, these are difficult to understand. Global aphasia is both non-fluent plus fluent. If you just mix, this will cause the global aphasia. Okay, a few other extra things, that is shuttering is due to right cerebral dominance, due to right cerebral dominance. Okay, facial recognition is done in the infratemporal lobe damage. If infratemporal lobe is damaged, it will cause prosopagnosia. And prosopagnosia means inability to recognize faces. Okay, another thing is the acalculia. What do you mean by acalculia? Is that selective impairment of mathematical ability. Your mathematical ability is impaired. Okay, this is due to frontal lobe lesions. Okay, to frontal lobe lesions. Okay, so if this is done, okay, let's move on to a few important things also. That is so a thing called as traumatic brain injury, TBI. Okay, traumatic brain injury is a non-degenerative it's a non-congenital injury. Okay, this is caused due to falls. Okay, motor vehicle accidents. Okay, assaults, or this is just striking of objects and all. Okay, TBI may be of primary stage or maybe of secondary stage. Primary stage is due to mechanical forces like skull fractures, okay, like skull fracture, contusions. The secondary stage is due to impaired cerebral blood flow, impaired cerebral blood flow, okay. And the TBI, the degree of TBI is measured by a scale called as the Glasgow coma scale, which rates the severity of TBI, okay, which rates the severity of traumatic brain injury. Next we have learning and memory. So memory is of two types. Memory is of explicit memory or implicit memory. Explicit memory is also called as declarative memory, and implicit is also called as non-declarative memory, okay. Explicit memory is associated with consciousness, okay, factual knowledge about people, place and things. And implicit memory, the retention does not usually involve processing in hippocampus. In this, the hippocampus is involved. The factual memory of the factual knowledge. Here the hippocampus is not involved. Okay. The declarative memory can be of semantic type or episodic type. Semantic or episodic. What do you mean by semantic? Semantic means facts, remembrance of facts. Episodic means remembrance of events, okay. And the non declarative type can be a procedural, can be a priming and perceptual, can be of associative learning and can be of non-associative learning, okay. Implicit memory, this implicit memory, if we just in simple words, it can be short term memory or a term called long term memory, okay. Long term. In short term memory is also called as the working memory, okay. It's just remembers the facts up to seconds to hours, okay. But the long term memory, it takes years to lifetime. You remember some event from years to lifetime, like a major thing that changed your life, okay. The elders must be that saying some event that occurred in their childhood, okay, that has been feed in their long term memory. Short term memory to long term memory is consolidated by hippocampus. We saw earlier, hippocampus consolidates short term to long term, okay. Another thing is a disorder called as the retrograde amnesia. What is retrograde amnesia? It is the loss of memory of events immediately preceding a brain concussion or electroshock therapy. Loss of memory of events immediately preceding memory loss, okay. Just a event occurred and you forget all which was happened in the past life, okay. Your previous life that you are living, remember all the events from now on, okay. So retrograde amnesia is this type of disorder, okay. Then a question comes that conditioned reflex, okay. Conditioned reflex is an example of associative learning. And associative learning in turn is an example of implicit or non-declarative learning. Understood. So conditioned reflex, what do you mean conditioned reflex? Like Pavlov experiments, okay. Pavlov experiments, you must have heard that salivation and that ringing of the bell, okay. Pavlov experiments. These are all conditioned reflexes. Salivation induced by placing meat in the mouth of a dog and ringing the bell and all. Next we have a disorder to explain, that is Alzheimer's disease. Alzheimer's disease. Okay, let's talk about the Alzheimer's disease. So Alzheimer's disease is short note, can come as a short note, that is the most common age related neurodegenerative disorder. Okay, it's a loss of episodic memory. Okay, loss of short-term memory. Agitation, depression and death may be occur. Okay, it may be sporadic, maximum cases, or familial. Maximum it is sporadic. Okay, 95% of cases, and familial 5% of cases. Causes of Alzheimer's causes may be many, like mutation in gene mutation for amyloid precursor protein on chromosome 21. Okay, mutation in presenilin 1 on chromosome 14, and mutation in presenilin 2 on chromosome 1. Okay, understood. Now we have the lab diagnosis. We can see neurofibrillary tangles, made up of tau proteins and amyloid plaques. Okay, and degenerated neurons. What are the risk factors? The risk factors of Alzheimer's. Okay, age is one of the major risk factor. Family members, if there is dementia. The disease is also familial, as I told earlier, 5% is familial. Okay, so and genes also, the genes. Which genes? ApoE4 gene, APP gene, PS1 gene, PS2 gene, and a person with Down syndrome can also suffer from Alzheimer's disease. Okay, then fourth one is the environmental factors can start developing of this. Okay, so this is a low educational level background. Okay, trauma, some infectious agent like prions are known to cause Alzheimer's disease, toxins and viruses. Okay, these are the environmental causes, that environmental risk factors that can cause your Alzheimer's disease. Okay, after this we can move on to a last topic, that is sleep. Okay, and this is our last topic, and I am already sleepy, so let's finish this topic ASAP. Sleep. Okay, sleep. And before sleep and EEG, sleep and the topic called EEG must be always learnt within, must be learnt like this in that format, that they are just combined to learn. Okay, so application of EEG. What is EEG? EEG is the electroencephalogram, which is the sum of electrical activities of your brain. Okay, so application is direct diagnosis of subdural hematomas. You can diagnose the subdural hematoma diagnosis. Okay, diagnosis of subdural hematoma, and lesions in cerebral cortex. Okay, cerebral cortical lesions you can find out, and you can find out for seizures also. Okay, so seizures. What are seizures? Let's talk about seizures. Seizures are like epilepsy. Epilepsy is the recurring seizure, unprovoked seizure due to brain damage. Okay, seizures may be like partial seizures. Let's talk a little bit more, like it may be partial seizure or it may be generalized seizures. Seizures are partial or generalized. So partial seizures are called as focal seizures, and generalized seizures are involve both hemisphere. Partial is involving a little hemispheres. Okay, the partial part, that is maybe simple or it may be complex partial or simple partial, and generalized may be convulsive and non-convulsive. Simple is due to without loss of consciousness. Consciousness is not lost, that consciousness is present, and complex, the consciousness is lost. Okay. Absence seizures is a type of seizures. Absence seizures, which are also called as petit mal seizures. Okay, absence seizures, these are non-convulsive in nature, non-convulsive but generalized seizures. Okay, and loss of consciousness occur. Non-convulsive generalized seizure, and that involve the loss of consciousness. Okay. In absence seizures, you can see the spike and wave pattern. The spike and wave pattern is seen in the absence seizures. Okay. If you see the EEG patterns. Okay. Another seizure is called as the tonic clonic seizures. Tonic clonic seizures are also called as the grand mal seizures. Okay. Now, like it has a tonic phase. Okay, sudden onset of contraction, like 20-second tonic phase, and has the clonic phase, like 1 to 2 minute. The symmetrical jerking. Okay, sudden contraction is there, then jerking is there. Sudden contraction is there, then jerking is there. It is the most common convulsive generalized seizure. Okay, fast EEG activity is irregular and fast. Okay. Childhood absence epilepsy is due to mutation in GABRB3 gene. Okay, GABA receptor GABRB3 gene mutation. This causes the childhood absence seizures. Understood? Childhood absence seizures. Drugs used for seizures. Some drugs not much important. Drugs for seizures, you'll read it in pharma, so here it is not there. There's a drug called gabapentin. Okay, then a drug is called topiramate. Third drug is called ethosuximide, and fourth drug is called valproate and phenytoin. Okay, so valproate and phenytoin, this generally act on your sodium VGCs and reduce glutamate. Okay, this ethosuximide, these are low threshold, act on T-type calcium current. Okay, this ethosuximide is used for your absence seizures. Okay, this is used for your absence seizure. This topiramate, this also blocks the sodium VGCs. This acts on sodium VGCs. Okay, and increase inhibitory effect on GABA. Okay, GABA inhibit the inhibitory effect on GABA, increases inhibitory effect on GABA. Gabapentin is the analog of GABA. Okay, it is the GABA analog. It's a GABA analog which decreases calcium entry to cell, decreases glutamate release. Okay, then let's talk about the sleep wake cycles. Okay, sleep wake cycles, we have few rhythms we need to understand. If a relaxed human is their first rhythm, if a relaxed human, relaxed eyes are closed, and he is awake. Okay, he is awake, relaxed, and eyes are closed. Then alpha rhythm is generated. Alpha rhythm is generated, which is 8 to 13 hertz in frequency and 50 to 100 microvolt amplitude. And if the person is alert and attention concentrated, then beta rhythm is produced. Beta rhythm is there. Okay, alpha rhythm is okay, alpha rhythm and beta rhythm. Alpha rhythm is decreased. Okay, this is decreased during alcoholism, okay, or amphetamines or barbiturates or phenytoin. If you take these drugs, there will be decrease in your alpha rhythm. Okay, now talking about non-REM sleep. Okay, we have REM sleep and non-REM sleep. So in non-REM sleep, we have stage 1, we have stage 2, we have stage 3, and we have stage 4. Okay, 4 stages of non-REM sleep are there. In stage 1, and the wakefulness to sleep. Okay, here we can see the theta rhythm. Here you will find the theta rhythm. Here we can see sleep spindles plus K complexes will occur. K complexes will occur. These are high voltage waves. Okay, high voltage waves. If someone just starts sleeping, so sleep spindles are sinusoidal waves. Okay, sinusoidal waves, and K complexes are high voltage waves. Okay, these occur. In stage 3, high amplitude delta rhythm is seen. Delta rhythm is seen. Okay, delta rhythm is seen. And stage 4, there is slowing of EEG, and your large waves are seen. The waves are large waves. Understood? Large waves are seen. Understood? After this, we can have REMs. Non-REM sleep is done. We can have REM sleep. Okay. Talking about REM sleep, what are the characteristics of REM sleep? So there is rapid eye movement. Okay, the name suggests, rapid roving eye movement. That is recorded. Roving eye movements are recorded by the electrooculogram. Okay, and there is a loss of muscle tone. REM sleep is called as the paradoxical sleep. It is called so because the brain is active. Your brain is active, but your other things are just inactive. Okay, the brain is active and metabolism is active. There is a low amplitude, high frequency activity. Okay, in EEG, your important thing is your pontogeniculo-occipital spikes. Okay, this is called as PGO spikes. These are PGO spikes. These are the characteristic of your EEG in your REM sleep. Okay, so if you do PET scan in REM sleep, then it will show increased activity in the pontine area, in your amygdala and your anterior cingulate gyrus, and decreased activity in prefrontal and decreased activity in parietal cortex. Okay, in CT, in PET, in PET scan. Okay, so distribution of sleep cycles is that if you sleep, first appears non-REM, then you transit to stage 1, then transit to stage 2, transit to stage 3, okay, stage 4, and then you go to REM sleep. Okay, so 4 to 6 REM episodes occur each night. Okay, each night you can have it 4 to 6 REM episodes that can occur each night. Okay, so another thing is that dreams that occur during the REM sleep, like you dreamt of something in REM sleep, they tend to be longer dreams and visually more appealing. Okay, visually more appealing than those during non-REM sleeps. Okay, then we will go to the sleep disorders, which are common nowadays. Sleep disorders, let's discuss this. And the first one is a narcolepsy. Narcolepsy is the brain cannot regulate the sleep wake cycle. Okay, the cataplexy occurs. Cataplexy means your muscle tone is decreased suddenly. Okay, and irresistible urge to sleep during daytime, excessive excessive day sleepiness, plus episodes of paralysis. Some episodes of paralysis also occur. Understood? Now second is obstructive sleep apnea. Here in this disorder, patient snores. Okay, start snoring. Okay, patient starts to snore, then snoring gets on louder. Okay, the snoring gets on louder, then interrupted by apnea occurs suddenly. Like the patient starts snoring, the respiration like this, it starts on increasing, then apnea. Then again starts his snoring, action apnea. Okay, it gets on louder, then in the temporary period of apnea occurs here. Okay, temporary period of apnea occurs here. So this is the obstructive sleep apnea, most common cause of daytime sleepiness. Okay, due to fragmented sleep at night. Okay, this is treated by the treatment of OSA, obstructive sleep apnea. This is treated by your continuous positive airflow pressure. Continuous positive airflow pressure, that is called as CPAP. Third disorder is the periodic limb movement disorder. Periodic limb movement disorder, that is called PLMD. What is PLMD? It is similar to the restless leg syndrome. Restless leg syndrome, which is also called as the Williams-Ekbom disease, is irresistible urge and rhythmic, shallow, continual movement of ankle, okay, or toes. Okay, starts with the rhythmic shallow continual movement of ankle or toes and can range up to strenuous kicking. Okay, sorry for disruption. Okay, so it can range up to strenuous kicking of legs and arms. Okay, strenuous kicking of legs and arms. So this is called as your PLMD, or your periodic limb movement disorder. Okay, and another disorders are there. Some disorders like called as parasomnias. Importantly, parasomnias are of three types, like is usually of somnambulism. Somnambulism is a sleepwalking. Okay, Then second one is the nocturnal enuresis, that is your bedwetting at night, nocturnal enuresis. And third one is the night terrors, hallucinations. Okay, these are your parasomnias. So here we complete the sleep disorders. With this we complete our neurophysio. It has been a long lecture of 4 hours and 20 minutes, 4 hours and 20 minutes around. Okay, so okay, no problem, but we revised our neurophysiology in all possible detail. We drew all things. I haven't used the PDF at all. Okay, I have written the things and taught to you. It gonna be good, very good revision session for you all. Okay, I have tried to cover all the possible topics as PG point of view is concerned, NEET PG, as well as the NExT, as well as the Prof is concerned. Okay, I have taken the reference of the standard textbook, that is Guyton, Ganong and your Burney and Levy physiology. Okay, for things for neurophysiology it is now done. And if you have questions like I haven't taught the vision, the hearing and all, that's the part of your special senses, the vestibular apparatus also I'll teach if I take classes of your special senses also. Okay, so neurophysiology, the core part of the neurophysiology, that is your motor system, the sensory system, the cortex, the speech, the language, the ascending tracts, the descending tracts, postural regulation, the speech, language and all, the about pain, the receptors, the synapses. Okay, then basal ganglia, cerebellum, we discuss it all in complete detail and with complete things on that clinical things. Okay, so I hope you loved the lecture. It has been a long time and it is already 2:43, around 3 at night. Okay, I will gonna sleep. So good night, and hope you had a good revision. If you like the video, do like, share and subscribe, and look forward for further lectures. Thank you all.